Thank you very much. Can I say welcome to those of you who are in the room and to all board members joining us on Teams, and especially, as ever, a really good welcome to members of the public joining us. This meeting is live streamed and a recording of the meeting will be on the Trust YouTube channel. For members of the public, can I remind you that we do have the feature of the live subtitles, and they can be accessed by clicking on your screen. Can everybody please remember to mute their mic if we're not speaking? And can I make a particular plea to people who are making presentations to just present us with the key points. You can be assured we have read the reports and we are really ready to have the discussion. So if people could keep their presentations really down to about 2 minutes. Now, some people in the room know that there have been prizes for getting the best succinct presentation, and I just hope some of you can get prizes today. We'll ask questions when the speaker has finished, and we're going to go on doing our best to avoid the use of acronyms. For members of the public, you can raise any questions that you would like to using the Q&A function on our MS Teams, and they will be reviewed by our company secretary as per the protocol that's set out in your agenda. Questions that you may have will be asked at item 16, where we have a maximum of 15 minutes allocated. The company secretary, Sian, will ask a question on your behalf, and I will seek a response from the relevant director present. If we're not able to do that verbally immediately, then I will ensure a written response is provided to you, which will be included in the minutes. We're seeking to conclude our meeting around about 2 o'clock today, and there will be a 30-minute break for lunch after item 11. I have received apologies for absence from Alistair Grant, our Chief Medical Officer, and Jill Derrick, Deputy Medical Director, is in attendance. Thank you, Jill. And I've also got apologies from Tom Lafferty, Strategy and Performance Officer, and Ella Strachey is joining us in his stead. Thank you for joining us, Ella. Also, a little way along the line, about 10 o'clock, we'll be welcoming John Govert, the Chair of the Cornwall and Isles of Scilly Integrated Care Board, and Kate Shields, the Chief Executive of the Integrated Care Board. They will be attending for item 8. They're not immediately able to join us, but they will be joining us later. So, colleague board members, are there any declarations of interest on today's agenda? No, I'm happy to take shaking heads. Thank you very much. It's very odd to actually be in the room, not all of us on screen, having to look at shaking heads and at screens. So thank you for that. That comes to item 3, the minutes of the previous board meeting. I'm going to assume we have read this, and I'm inviting you to approve this unless there is anything material anybody would like to raise. No? In that case, please could we note our approval in the chat. That then brings us to the log of matters arising and actions proposed as complete. So I'm going to again assume that we have read this, and are there matters that anybody would like to raise on the action log? I do have a couple. Kim.
So if I could go to the very There you are, I'm the first one to forget to put the mic on today. Can I go to the last one, please, on the Freedom to Speak Up Guardian biannual report? So if we could just square that off. Joe and I are busy. It will go to pod next month. We're just busy collating that, and it will cover all the themes and trends at both a trust level and a care group level.
Thank you, Kim. That is very helpful because it's just... This is a really important thing to jump on, isn't it? So that sounds really timely. Thank you for that. Are there any other points from the action log? I just have one other one, briefly. Jill, you may or may not be able to respond to this. On the sepsis guidance, says that it's going to be reported back through QAC, which is entirely appropriate. And I just wondered what the timing would be on that. Timescales, please.
Yes, indeed. So we're tracking it continuously using the current sepsis guidance, which is antibiotics within an hour. We've got the pilot going on in the emergency department with the new guidance, where there's 2 cohorts of patients, high acuity needing antibiotics within 1 hour and lower acuity within 3 hours, to allow a bit more time for diagnostics, etc. So our electronic tool for the wider trust is waiting to be updated with the NICE guidelines. At the moment, these are just Royal Academy, the Academy of Royal Colleges guidelines. And so the timing for that is probably not until the new year. We've got a couple of representatives from RCHT on the stakeholder working group developing the NICE guidance. So we've actually got an input into that, which is great. So once the NICE guidance is approved in the new year, we will then have our electronic tools updated to the NICE guidance. So we've got a bit of time to roll out the training and continue with our manual audits and other audits between now and then.
Thank you, Jill. That's really helpful, so that we can be assured that the sepsis is being administered as per current guidelines. And it's really good, to our credit, to hear that we're in there with NICE making the decisions. So thank you for that. Does anybody have any further comments on the action log? In which case we'll take the log as proposed in front of you. Thank you for that. Which brings us then to item 5, Kim, our patient story. And again, as people are aware, we do see this as a very important item. This just reminds us while we're all here, and it's very important for us to hear both from staff and from patients about their experience, and hearing it in this manner is really great. So Kim, if I can ask you to introduce that. Thank you.
Thank you, Maury, and welcome to Emma Wise, who is the Deputy Head of Nursing here at RCHT for our urgent and emergency services, who'll also be able to answer questions following the video. Could we go to the first slide, please, Pete? Suspense. Oh, thank you. So today we're going to hear from Tom himself tell his story of his experience in ED. We talk a lot about the pressure and the pressured environment and the overcrowding of our ED department, but I think it's really important that we don't forget the patient experience in this. So if we could play the video, please.
In the middle of the night, I was suffering from pains in my top of my arms, and also I realised I was going into alcohol withdrawal, and so I called an ambulance. They came out and took me down to Trelisk, and I went straight in, and I went into a side room, and bloods were taken. I was given a thiamine tablet and some fluids, and then I was moved into a cubicle. I just was a bit anxious, to say the least, about being in hospital. A nurse came to see me. I was given the buzzer, and I was told that if I needed any assistance to press the buzzer in the cubicle. And then I just laid there. The nurse did come in again to take my blood pressure, but then I started to feel worse in myself. The alcohol withdrawal started to really kick in. And it's a really unpleasant experience, and unless you go through it, it's not a hangover. It's one of the most horrible sensations and feelings, mentally and physically, that I personally experienced. And so I laid there, I began to shake. I did press the button to get some assistance. That seemed the only thing I could do, because people were busy and I could see people walking up and down, and I thought, well, I need some help here. And so I pressed it and I pressed it and I pressed it, and I can't remember how many times, to be honest. I say 30 times. It could have been more, it could have been a few less, but nobody came. And so it got worse. I remember the nurse coming back in and asking me some questions about did I know where I was. It was all about alcohol withdrawal questions. I've had these before. I answered them the best I could, I did ask her at one stage if I was dead because nobody had come, and I thought, well, perhaps I've died, and that's why no one's coming, because you know they don't need to. It's a bit of a silly thing to think, but in alcohol withdrawal, that's the kind of thing that goes through one's mind. She went away again, and nobody came back. I could hear loads of people talking. I looked across the way, and there were workstations with, I guess, doctors and nurses at those stations, and there were people working. I could see scans of people's skulls and various other things, but I did notice that there were people chatting in general, just about life, just about things, and I thought, why am I not being seen to if they're not that busy? I did try at one stage to call to somebody who walked past, but they probably never heard me. And so I just waited, and it seemed an eternity. And at one stage, I thought that I was going to die in there. What a place to die in, on my own, in a cubicle. And then at one stage, I thought, well, if no one's going to come, if I can get off of this trolley, I can get out of this hospital, I can go into the town, and I can buy alcohol, because that will stop it. But I couldn't get off the trolley. And that, to me, went on for ages. It was about, I can't give you the exact time before I got treatment, but it was over 3 hours. To be fair, I saw a doctor, and he was pleasant. He said that they would treat me for the withdrawal, and that once they'd got me stabilised, I guess, then I could go home, because it wasn't the place to be treated for alcohol withdrawal. So I did speak to the alcohol liaison team, and again, I've spoken to these people before, and I was quite happy to engage with them. After that, I did receive 2 more doses of medication, and time just went on. I just laid there, and by the time I was discharged, I was still wobbly on my legs, I was still shaky a bit, but it was enough. I could function just about. And so I made my way home. If it had been really busy there, I could have understood partly why I wasn't being treated, or somebody was keeping me up to date with what was going on, but it wasn't busy. And how I felt, I mean, to me, it was during that time being in that cubicle, it's a terrifying experience. I didn't feel safe. Nobody communicated with me about what was going on. I just felt abandoned, basically. I just felt like nobody cared. I mean, I was probably projecting what I was thinking, but I just felt, well, they've probably seen me before. They just say, here comes, an alcoholic who has got himself into a difficult situation, and now he's down here expecting us to sort him out, which made me even feel worse, because it makes me feel worthless. But overall, it was just an unpleasant experience. I'm not planning on coming back to Treliske at all. It doesn't work like that. But the fear, if ever it happened again, would be like, oh no, I've got to go there. I shouldn't think like that. I just wanted to feel safe and looked after and treated as a human being. And I didn't feel I was. I mean, nobody was horrible to me. I must say that nobody said anything horrible to me, but it was that period of pressing the buzzer, seeing people chatting and on WhatsApp, and nobody coming to me, and shaking and sweating, and that awful fear of dying. I didn't feel I needed to go through that. I did go home, and I still am off the alcohol, which is good. I just wanted to tell this story to help the trust, and also to help other patients that go in there, because I know there's quite a few people that do go into hospital with alcohol and other drug problems. So yes, that's basically my story.
to thank Tom for sharing his story. It's really important about trust-wide. Thanks, Pete. It's really important that communication with patients, often with centralised workstations, it can appear that staff aren't busy. Electronic, where people talk about WhatsApp, actually we all know that lots of our work happens on iPads, iPhones, so that communication and explaining really is important. We're doing a trust-wide communication leaflet. ED have worked really hard in using a toolbox. Everybody needs to feel valued. Everybody needs to be treated with privacy and dignity. Next slide, please, Pete. Next one. Most importantly, and Emma can definitely talk about it, it's really understanding the human factors that the patient feels, and for staff not to have unconscious bias as well that you heard Tom speaking about. The senior ED team are working really hard and collectively to make sure that staff have mandatory training, patient experience, how to handle difficult situations. They also recognise in their own team the effects of staff burnout, and sometimes how people can just, sometimes not notice that someone is in distress, and it's that compassionate fatigue that they feel. And we've also got extended health and wellbeing strategies in place for our staff. We're also looking at how we use the voluntary sector as well. Our patient experience ambassadors, especially for patients who need that expert signing that could, working with the system, prevent them coming into ED in the first place, which is really important. And always we try and strive to provide the best patient experience for our patients where they can feel safe. So it's really important to hear when we don't get it right and how we manage to, how we fix that, so to speak. So thank you. Just over to questions either for myself or Emma.
Thank you very much, Kim, and our hearts go out to Tom, because it sounds as if he did have a very frightening experience, and I totally endorse what you've said, Kim, about how we support each other in keeping up our compassion for that. Sarah Newton, you want to come in?
Yes, thank you very much indeed, and Kim, thank you so much for sharing that story with us. It is really hard to hear, but really important, and it's really assuring to hear about the plans that you and the team have got to support staff to deliver that compassionate care in very challenging circumstances. My question is, to Tom's great credit, clearly he wants to stop being an alcoholic and was trying really hard to do that when he arrived with us. Are there services in Cornwall where he could have gone to give him the appropriate support with the side effects of alcohol withdrawal rather than a busy ED department?
Come in on that one. Yes, there are, and that's where the expert signing comes into it. So we do have a very active drug and liaison team, both in the acute, but we have them in the community. So part of the learning is how, as I said, how do we prevent, when people do need treatment to come in, but actually how do we prevent Tom getting into crisis and having to come into ED, and how we work with our community partners to make sure that they're picked up before they're in crisis.
Thank you very much, Kim. Richard Stevenson.
Thank you, and thank you again, Tom, for sharing that experience with us. What I wasn't sure of was the timeline of when this might have happened, and I understand the plans that we've got, etc. But if this was a while ago, what has happened already to ensure that experience isn't repeated?
It did happen a while ago. So it's taken a while to get the illustrations and get the story together. So the team in ED, as Kim said, have been quite productive in recognising what it was that happened to the staff to allow such compassion fatigue to the point where Tom felt that he wasn't safe. So as an immediate step, we recognised that the staffing in ED was below what we felt it should be to be able to deal with the demands. So we've increased the staffing by means of agency, and as Kim mentioned in her paper, we've also written a summit paper requesting some more staffing for that to be substantive, and to help with all sorts of wellbeing packages as well. We've also instigated a lot of TRIM training with our staff, so the hope is that every member of staff who works on the emergency department will have access to someone who is TRIM trained. Now, this is someone who specialises in dealing with trauma and difficult situations, who can expertly debrief whilst on the scene, because it's recognised in the emergency department. So Tom's story was clearly the worst day of his life. He was experiencing a horrendous time, yet for us that's every day. We do get overwhelmed with that, and it can be very difficult to bring yourself back to recognising that that's someone's worst day. And so it's about helping our staff to overcome that compassion fatigue. So it's realising the problems that they had on the floor, so increasing the numbers, increasing their resilience and well-being and their own safeguarding, so that they can then project kindness and compassion as we would expect them to be able to do so.
Want to make any further comment? In which case, perhaps then I can conclude, unless you have anything else you'd like to say, Kim.
Oh, just to extend our thanks both to Tom and to Emma and the senior team, working in really challenging environments, but also taking time to recognise both staff safety and patient safety and experience in that. It's really, really comforting to hear, and thank you very much, Emma and the team.
Thank you, Kim. I think, Robin, you wanted to come in.
I was just going to echo exactly that. Firstly, thank you, Tom, for being so brave to share that story so openly with us. But I think the important thing for us as ED department, senior management and as the trust board is that we have this really open conversation that actually this didn't go right for this gentleman. As you described there, Emma, for our teams in many regards that can be a normal day, but for him it was for his worst day. And that work that you're leading in the team to get the team into that space where they understand that for each individual it is their worst day and how we work differently with them. I just want to say thank you, Emma, for encouraging your team to be so open with that conversation.
Thank you. It's very kind.
Thank you, Robin. You make an excellent point, because we don't always get it right, but being able to share when we don't is so important, so we can learn and put it right. So I'll just echo the thanks, particularly to you, Tom, and your friends and family, and also Emma, on behalf of your whole team. Thank you very much for everything you do, not just for this one example. We're really grateful that you've taken time to be with us today. Thank you for that. You're very welcome, Emma, to stay for the rest of the meeting. You may or may not want to, but you are most welcome.
I wish you'd talk on the floor, but thank you very much for the opportunity.
No worries, thank you. So, board, thank you very much for that. We now come to my report at item 6. I won't go over the report, you have it in front of you. I'm happy to take questions, and perhaps while anybody's thinking of any, I would just like to particularly welcome the return of the non-executive director and director walkarounds on site. As people probably know, it has been a long time since we've been able to do these things, and we've not only missed them, but they are a very important part of the work that we do as a board. So we're absolutely thrilled to be now able to get back to those programmes of walks, which enable us to meet both patients, relatives and staff, and to listen to them, and to give assurance that anything that we do here is brought back and discussed with the relevant executive, and then any things that need to be acted on are reported back through our Quality Assurance Committee. So it's not only a joy for us to be out with you, but it is a really important part of the work that we do. The word triangulate, when it was first used to me as an executive, non-executive, I really didn't get. But actually it's really important that we see and hear from people as well as we read reports and we feel things for ourselves. So we are genuinely thrilled to be back. The only other point that I wanted to make, and I think Kim and Emma have already made that point, in addition to the notes there, is just to, again, acknowledge and thank what staff do for us, because we've talked for the last 2.5 years now about what challenging clinical times we're in, but we all know we're now in very challenging economic times. And as a team and as a board, we are mindful of needing to make sure we take as many actions as we can to support people. We're completely dependent on our teams. As citizens of Cornwall, we're dependent, and we do want to thank you for what we do. I think you might see in the Equalities report later some of the things that we are already doing. So that's all I need to add, and happy to take any questions. No? In which case I think we can pass on, Chief Executive, to your report at item 7, please.
Thank you for that. That's really helpful. I'll take the report as read, but there are a couple of aspects I would like to draw out, given their importance, and also 2 matters to provide a further update on. So I'll start with the updates. The paper provides a summary of some updates to executive portfolios, but also in section 14 provides an update in respect of executive recruitments. I'm really pleased to be able to update board that we've now finalised arrangements in partnership between Royal Cornwall Hospitals NHS Trust and our community partner, Cornwall Partnerships NHS Foundation Trust, such that rather than each of those 2 separate organisations progressing with recruitment for a Chief People Officer and also recruitment for a Strategy and Transformation Director role, that would be 4 roles, we've been able to conclude arrangements to agree dual appointments across the 2 trusts. So the update to that particular item is both our organisations will be intending to appoint 1 single dual Chief People Officer and 1 single dual Director of Transformation and Strategy. That will be a significant step forward for both of our organisations in a number of areas, and I think particularly the dual Chief People Officer is an important development. As board members are aware, in developing a provider collaboration between our 2 organisations, one of the key intents there was the principle of a one workforce approach to support and enable staff to work more flexibly across the 2 organisations, and as we're in a small locality, to seek to align reward and terms and conditions and other aspects of staff experience, and a dual Chief People Officer will be instrumental in progressing that. So that's a very positive step forward. Similarly, the opportunities for transformation across our 2 organisations to improve patient care and to reduce avoidable delays in our system will be significantly enabled by having a single dual Director of Strategy and Transformation in the 2 organisations. So that's a significant and a really positive development to those matters that are reported in the board paper. We'd expect to be undertaking recruitment for both of those roles over the course of the next 4 or 5 weeks, which should lead us to a position of being able to interview and hopefully make appointments at a point during October. So they're the updates in respect of those 2 roles. The other role that's noted in the paper, the Royal Cornwall Hospitals NHS Trust Chief Operating Officer role, continues with recruitment as set out in the paper. We've had a strong field of applicants for that role, and I'm looking forward to the next stage of the recruitment and selection processes partway through September, and I'll update board as that concludes later on this month. So that was the first item to update on. The second point briefly to make is around the governance improvement plan, and just for a point of accuracy, actions 19, 20 and 21 are set out with a requested updated target date. That updated target date should be February 2023. The paper says February 2022 for those 3 actions, so apologies for that. And when we come to board approval for a consideration of those updated timelines, it's February 2023 for those 3 actions, actions 19, 20 and 21. I did want to briefly provide some more context on the operational pressures that are set out in the board paper. It's certainly the case that Royal Cornwall Hospitals NHS Trust continues to see significant pressure and significant delays in our emergency department, as do our ambulance service partner South West South Western Ambulance Service, continue to see significant delays in ambulance handovers and in ambulance response times. The pressures that continue in our organisation are set out in the paper. There's also a link to the letter from the NHS England National Chief Executive, Amanda Pritchard, and that letter is, I'm sure board members will see, Amanda is clear nationally that integrated care boards across the country have been clear with NHS England nationally that much of the pressure across the country on emergency care is driven by the current significant and growing strain on social care. So I think that letter is clear that the challenges that we face in Cornwall and the Isles of Scilly are challenges that are being faced right across the country. One of the things that is specific to us, though, as we've identified, is the particular exceptional pressure on staffing in social care in Cornwall, and the report sets out CQC's assessment that they found that adult social care staff vacancies in Cornwall were one of the highest in the country. So whilst those pressures are felt right across the country, there are some significant additional pressures in our area. I also wanted to briefly comment on winter preparation. The winter plan is set out in the board papers, so I won't cover that. What I will say, though, is going into this winter, there are clearly some additional pressures that the system has not experienced to this level before. And perhaps the most outstanding one of those is the extraordinary inflation on energy costs. The reason I mention that is that is likely, in my view, to have an impact on the financial viability of some smaller care home operators who generally operate with very small financial margins, and significant increases, as is being experienced right now in terms of energy costs, could have the potential to impact and potentially undermine the financial viability of some of those smaller operators. That's a challenge for us in Cornwall. I also have raised that with NHS England nationally as a potential challenge that could be faced elsewhere as well. So we'll be working very closely with our system partners to seek to, as best we can, identify those kind of risks and challenges and be in a position as best we can to respond appropriately. Our system partners are working incredibly hard in the system-wide actions to prepare for the winter as well, and we're certainly grateful for that support. The final really brief comment is around elective performance. The position at the end of August in respect to those patients who are waiting over 104 weeks for their elective services was a total of 2 patients. But both of those patients had been offered an appointment in August, but that appointment wasn't a one in which they could accept. So we'd expect those appointments and those arrangements to be put in place in September to provide the opportunity for those final 2 patients waiting over 104 weeks to receive their definitive treatment or intervention. On the one hand, that's very positive. That's a significant step forward for us. But of course, for all of those patients that are waiting just under 2 years, that's a real priority for us to address and continue with our plans to enable no one waiting more than 78 weeks by the end of March 2023. Happy to take any questions on any of those matters or anything else that's in the report.
Steve, thank you very much. It was a comprehensive report, and I know with appendices, and so just perhaps draw the board's attention to our need to give consideration, in particular to CFT's strategy. They've posed some really helpful questions for us, but also any questions that anybody has for any of really a number of matters that you're raising with us this morning. So thank you. I've got Sarah Newton first, please.
Yes, thank you very much, Steve. As always, a very comprehensive and thorough report, which is much welcomed. You were mentioning about in your update, we had some good information about patient flow, and it was really pleasing to note that the very senior people that have visited us from our regulators, from NHS England, to try and help us to identify what more we can do as a trust to improve patient flow, actually pretty much said that we were doing everything that we could. We're never complacent, I know, and I know you're never complacent, and working very hard on that. You also mentioned that you had really good support from our systems partners, and it's great that we've just had Kate and John join us, and no doubt we'll continue this conversation after their presentation. And you mentioned what good working relationships there are at a system level and actions being taken to support patient flow. So I'm wondering if you could describe to us some steps that are being taken to increase capacity in the system so that people can leave the hospital and return to their own bed or a bed in a residential care setting, which of course is the right place for them to make a recovery.
Thank you very much, Sarah.
Yeah, thank you, Sarah. Really important set of questions. So firstly, very briefly, the hospital itself has taken significant actions to increase capacity, which, with a range of interventions that have either already been put in place or by November this year will create the equivalent of around 60 additional hospital beds or emergency department spaces. So those hospital actions are really important. From a system perspective, there is and continues to be a huge amount of work underway. They include significant steps to increase dementia bedded capacity in the community and also to increase capacity in the community to support people with dementia in alternative settings, in home and elsewhere. That's particularly important for us given the number of patients in our hospital beds who are awaiting discharge into a bedded care perspective. But much more broadly, there is a significant programme of work underway which is under the direction of the Integrated Care Board, and Kate, as Chief Executive, as you say, has just joined us, which is absolutely around aligning health and care services together so that we can enable people to be discharged most appropriately and not to default to bedded care wherever possible, to enable people to return to their own homes with a combination of health and social care. And that shift from a reliance from bedded care into enabling people to live their own lives in their own homes is really an important part of this. There are a range of other interventions as well, and I'm mindful that in our next agenda item, colleagues John and Kate will be talking about some of the steps that are being taken as well. So I might suggest that we cover those further steps at that point.
Thanks very much, Steve. I think that will be appropriate. Nina, you have a question?
Thanks, Steve. Really enjoyed reading the report as always, and the fact that we are picking on the challenges which are coming. I'd really like to focus on what the Trust is really doing well at, and how the assurance that we have that by trying to address the challenges that are coming, that we don't slip in the areas that we are excelling in, so that our patients and our residents actually feel comfortable that we are not only addressing our challenges but also keeping up the high standards of the really good areas.
Thanks, Nina. That's really important, and one of the challenges in the board setting, of course, is to provide that balanced reporting about the significant risks and challenges we face in the great areas of success. The work around the elective programme is certainly challenged by the emergency pressures that we face, but the steps that are being taken are clearly having an impact. And that trajectory of reducing the number of patients waiting more than 2 years certainly continues to be an improving position. Our Trust historically has performed really very, very well from a cancer services perspective. It is the case that cancer service performance overall is now under greater pressure with some of the flow challenges that are being faced across the system, but continues to be a comparatively positive performer. And just briefly on our ambulance response times in our emergency department performance. Performance comparatively in the last 4 or 5 days has been significantly better than it's been for the majority of the last 7 or 8 months. That is too soon to say that's a trend, but nevertheless it is a positive position. Our staff work incredibly hard to address that, and the work and the focus, particularly over the course of the last 2 weeks, has been outstanding, and it's very positive to see that starting to show those signs of a much better ambulance performance.
Thank you very much, Stephen. Thanks for the question, Nina. It is really important also to focus on what's going really well, because much is. So I appreciate the question. Ruth Allerton, you'd like to ask Steve something?
Thank you, Mari. Steve, reading our seasonal plan and looking at some of the targets we've got in there, one of the key factors that we need to achieve is our flu vaccination. We know from, or we think from information that we're getting from our Southern Hemisphere cousins, that flu may be a big problem this winter. And we know it's a target that we've struggled to do really well with in our organisation. So can you give us some assurance around what we're really doing to encourage our staff to get vaccinated, to support, to protect themselves and their loved ones during this winter period?
Kim, to initially address that.
So it's no secret in Cornwall, and we're one of those agencies, that our record of flu vaccination, I think we've reached the dizzying heights of 57.6% last year. So we've already started planning, and I believe there's a top secret video that has been filmed with some of our staff to be able to do that encouragement. We'll continue with our peer vaccinators. We're working across both RCHT and CFT to make sure we align, so it shouldn't matter which organisation or which team you're in, and I'm happy to extend that as well to other partners, to make sure that you're able to get your flu vaccination from a peer vaccinator. We'll have roving teams again, and we've found the most effective thus far, Ruth, has been the peer vaccinators, getting vaccinated by one of your colleagues. We've also got some surprise incentives this year as well to help encourage that, and we'll be having regular meetings and updates, especially focusing on where we'll know uptake hasn't been good. So lots in there, and we'll work really, really hard. Conversely, we're really, really good with our COVID booster vaccination, so we'll try and combine them.
Thank you, Kim, and for the question, Ruth, because I'm really pleased to hear what you said about extending that offer to colleagues across the system. I know some people in other organisations have expressed some concern about that, so I hope they can take assurance now that that will be available. Isabel Down.
Thank you, Mary. I don't know if this question is for Steve. You may want to divert to ask somebody else to respond to it, but I think clearly we're really reliant on really good clinical leadership and engagement with this whole agenda in dealing with the pressures facing us, not just through the winter season, but more generally in terms of the transformation that needs to take place. And I'm wondering whether there are any particular initiatives that are being considered to support the clinical leadership through this.
Yeah, it's a really important question, and certainly, Isabel, in approaching our winter plan and in approaching the additional extraordinary actions that we've taken, we have sought to enable that to be clinically led as much as it is absolutely possible, so that we can have strong alignment on the management of risks. One of the aspects that I think our Integrated Care Board colleagues have done particularly well is looking at the opportunities to risk share across the whole system, and that absolutely is clinically led to enable clinicians from across primary care, community care, mental health and acute care to consider what further steps and escalations can be taken. Those things have led to opportunities around virtual ward expansion, chest pain pathway management, falls response services, so that there's a whole range of opportunities there. Our clinicians, I would say, will are required to balance the risk of the patient in front of them with the system position. And it's really important for us as a board that we support our clinical colleagues in making those challenging decisions. And we've also had some of that discussion at a regional and a national level, so that we can provide the appropriate support in which clinical decision makers can be supported, empowered and safely make decisions in the best interests of the patients reliant on our care. I'd be very happy for Kim or Jill particularly to comment if either of you wanted to on this point as well.
Thank you, Steve. Kim?
So I think this is where the executive leadership group comes in as well. That's where our we say we're clinically led and our clinical directors attend. I believe there's been an away day as well where that was hosted by Alison, our Chief People Officer, to have a look at what support. We've got a half day away with the heads of nursing to make sure that we're in for a tough winter, we know that. What else can we do to wrap around some support, as well as looking at some additional support, especially for teams such as safeguarding. And we've had some business plans around that to make sure that some of the wider corporate services that support the clinical teams are well resourced to be able to do that.
Yes, thank you. So the Medical Director's Office obviously has a real ambition to support and develop our clinical leaders. And I run a Specialty Leads Forum, and we're developing a programme by which we can identify where people need that additional support and input and training and development, so that we can add the necessary resources and support. And similar with new consultants as well, in terms of any sort of person who's appointed and starting on their career as a senior clinical decision maker. It's just sort of getting in early, isn't it, and really providing the understanding and development that they need.
Thank you very much, Jill. Alison, just before I bring you in, I saw your hand up. There is somebody else who's got a hand up and I can't see who it is. I apologise.
It's Robin.
Thank you. Thanks. Robin.
Part answer Isabel's question and go back to Nina's, if I may, is some examples of what we're doing really, really well. The first one is our flow programme and the governance structure that's been put around that. So Ella and her team really hold us to account in our programme board to follow that really rigorous PMO structure. So we're not doing that classic throw new ideas at the problem. We're really using that PDSA, Plan, Do, See, Act, Study Act, where we take the data. If we're going to make changes to that programme, we use the data to drive those changes. Yesterday we signed off some new pieces of work to be done because the data told us we needed to. And I think that's a really strong example of how we're working differently now to try and tackle this problem. And then I've got two examples of part Isabel's question, which is we're clinically led from our frailty pathway changes. So Fraser Underwood and Laura Wesson are driving those changes, which are aimed at how do we work differently to prevent admission in the first instance. We know if we can turn some of those frailty patients safely home, we then don't create further demand for pathway 1, 2 or 3, which then is at part our contribution towards the whole system challenge that we've already mentioned. And that's underpinned again by our PMO structure to make sure that those get delivered. And the second one is Toby Slade is leading a whole system, so all colleagues across the system, review of that low risk chest pain pathway that Steve has mentioned with a go live date of 12th of September. Whereas a whole system we're working differently, and that's aimed at reducing up to 4 attendances a day in our emergency department, and well supported by our CFT colleagues. So they're some of the things that we really are starting to do well.
Thank you very much, Robin. That's really helpful. Kim, did you want to come straight back on that, and then I'll bring you in, Alison?
Yeah, it's really important. We've got the system-wide clinical cabinet, and that's where all the clinical leaders come together, because it isn't just we're part of a system, aren't we? So if we're looking at admission avoidance, how do we work with primary care partners, for example? How do we work as an acute, go on to a community? How do we work with some of our care home providers, which is really equally important? And then how do we bring the voluntary sector in? So we're trying. Being clinically led across a system is really powerful because that can influence the change.
Thank you. That's a very well made point. I'll bring you in, Alison, as our last speaker now on this item, because we need to move on because of time. Alison.
Okay. Thank you. I think Kim and Jill actually have covered the main salient points that I was going to raise. The only other point is around Alistair and I are in discussion around how we support our clinical leaders around resilience and coaching, and making sure, because we quite often promote our most clinically able, but making sure that actually that we don't forget that there are a basic suite of management development that everybody needs to be able to carry out a management and leadership role. Thank you.
Indeed, that's the backbone of it all, isn't it? That we make sure that we're doing that. Okay, colleagues. So just to note that there is a lot more information on some of the matters we've already touched on in today's board pack, which I must say I think is a really good board pack. So progress on the gap between the 19th of July and the 25th of August system oversight meeting is well documented, as are the issues that we're undertaking around bed capacity. I've got a tiny question, and then I want to comment on the CFT strategy. Steve, I note with pleasure that we've now got another memorandum of understanding in the wings with Plymouth, and my question is, how are we going to make sure that we coordinate the three different universities that we work with so that they're complementary?
We've had that discussion with each of the universities individually, and we've got a kind of an immediate approach to that, and a longer term intent. The longer term intent isn't agreed yet, so the immediate approach is to work with each of the universities individually on the areas of priority work, and for us to ensure that those priorities and that intent aligns from a Royal Cornwall Hospitals NHS Trust perspective. Where we'd like to get to is to have those conversations jointly with all three of our university partners, and that is something which has the potential to be put in place in the future, but that currently isn't the case. So we have that initial interim approach that we exercise, that's kind of assurance mechanism to see that the three separate arrangements are aligned, but with that intent that we can move from those one-to-one discussions to all four of our organisations, and actually broader organisations could form part of that as well.
Thanks, Steve. I think that is really important, so that it is collaboration in terms of what our priorities are. Before then coming to our various agreements and approvals, could I just comment on the Community Foundation Trust strategy? I really like the one-page approach there, and when I looked at it I was struck by how similar it looked to ours, which I think is a really good thing, and I know our next strategy is still to be signed off and further discussed. But I did like the approach. I liked the way it was laid out. It was really easy to read. We haven't had full time to make comments on the questions raised this morning. I don't know what the timescales are, but I wonder if people do have further responses for CFT. I would really like to see us make some. So perhaps in the next week or 2 weeks, we could address ourselves to the questions asked, particularly, which I thought was a really good question, the one that says, is there more we could do to help you? How could we be different? And I think we should put our heads to that. And I know there's lots of discussions going on, but I just think when people ask us for comment, it's nice to make it. So I'm going to bring us then to the various approvals. I'm then going to go back, with apologies, to item 6 because I failed to ask for an approval there. But if I could take item 7 approvals, please. And just to say, we have discussed and noted the current performance against the 100-day challenge. We're noting the development with Plymouth University, an intention to bring forward a memorandum of understanding in a future board meeting. We have had opportunity to discuss and comment on the winter plan. We're asked to endorse that. We're asked to agree the actions proposed as complete within the governance improvement plan, and to agree the new proposed deadlines for actions noted in your papers. And I also note the fact that the date is February 23, not February 22, as Steve has advised us. We're asked to delegate authority to the medical director or to our deputy medical director in his absence to sign off on the behalf of the board the Health Education England self-assessment, and further that we should note the remainder of your report. If colleagues would be good enough just to put one agreement or otherwise in the chat, that would really help me. And then I'll quickly go back to my item where I apologise. I should have asked for board to approve the delay of the schedule of board and committee meetings to the October Trust Board in private, to be reported to the November Trust Board in public. This is a variation to our standing orders, standing financial instructions and scheme of delegation as described in my report. So if you could separately approve or otherwise that matter. And while you're doing that, if I may turn to Kate and John and say I have already formally welcomed you at the beginning of the meeting, but thank you both very much for coming. It really is appreciated. And some of us have been saying how nice it is to see people in person. And so we're really looking forward to your item. And although we've run a little over time, you will have your full amount of time. So welcome to John Govett, who is the chair of the Integrated Care Board in Cornwall and the Isles of Scilly, and to Kate Shields, who is the chief executive of that board. Thank you both very much.
Lovely. Thank you, Chair, and thank you everyone for the opportunity. So with half an hour, I think probably the way in which we'd like to try and conduct this session is for Kate to go through the slides, do her introduction for about 10 minutes. I'll then try and do my sort of summary of things for about 10 minutes, and then leave about 10 minutes for a Q&A, if that's all right, Chair. Does that work for you? Lovely, thank you. So,
thank you.
Kate, over to you, please.
So, good morning, everybody. So I just wanted to remind everyone that the ICB has been in creation for 60 days. And what it is a fundamental change of legislation that actually starts to remove the purchase of provider split. So there shouldn't be a divide between commissioners and providers anymore, because the whole of the legislation is around integration. And I think that's going to be a challenge structurally and politically for the NHS, but it's one that we are being expected to address. We're going to go back 30 years in NHS policy so that we will have a pot of money for a population. Doesn't really matter which provider the money goes to, as long as we're improving the health and lifetime outcomes for those people. And as we're a small system, it makes it even more important that that integration word is the one that we use, because we can't have 2 or 3 of everything for a population of 650,000. So as we go through and as we go to the questions, I'm hoping that we can come back to that. So if we go to the next slide, please, Pete. So progress so far is all process and structure, which you won't be interested in. So I have to say, you are the ICB. So there's I hate the use of the word system, which anybody who knows me will attest to, because we are it. It's a collection of people who decide to come together to make a change for the people that we serve, and the Integrated Care Board is the structured way of bringing us together to do that. So on our board we have Mary as part of this organisation, and Steve representing all providers, not RCHT, but the provider interface with our Integrated Care Board. So we set up on the 1st of July, and the CCG was disestablished. On the 14th of July, we had our first IC board, and our second will be on the 8th of September. Many of my exec team have only been in post for 2 pay packets, so the operating model of the ICB is still developing. And in that, we will be having discussions with our exec colleagues across health and care and the voluntary sector around how we align our teams so they're facing the issues, not their organisations. So we've had some early successes. We've got an agreed operating plan for 22-23. It's got high levels of clinical and financial risk contained within it, and that is across all NHS agencies. We'll see how well that works as we go through this year. It's going to be one of our most difficult years yet, and I'd like to come back to winter, because I haven't seen your winter plan, but I don't think we're winter ready, and we are anticipating from the Southern Hemisphere that it's going to be a really difficult winter for our poorest, most vulnerable people, and there will be more of them this year because of cost of living increases. We had a True North event to which many people from RCHT came, including our clinical colleagues, because our power in all of this is getting our clinicians aligned with our citizens. So some of that democratic accountability that the NHS hasn't had, we start to reduce it, and we're providing services that our people need and want. So we have 6 strategic priorities for Cornwall and the Isles of Scilly. They weren't universally accepted by everybody, but they represent the best start for us as a system coming together. They will form the development of an integrated care partnership strategy, which we need to have in place by December 22. Rachel O'Connor from my team, who's our Director of Inclusion, and Rachel Rotherer from the local authority will be penning that strategy jointly based on our views. And we started an early review of our governance to make sure it works for our population. Governance shouldn't impede us in doing things. It should make difficult things possible whilst keeping us safe. And we need to make sure that we have that agile governance in place within the ICB, but between its constituent members. So Pete, next slide. Around January time, I feel like we were prophetic. We identified what we thought were going to be the most difficult issues for Cornwall and the Isles of Scilly. And that old adage of culture eats strategy for breakfast, operational pressure eats strategy for lunch and dinner. So if we don't sort out the things that are our Achilles heels in Cornwall, are the things that our population deserve better care for, then we will not ever be able to get to the point of looking at health inequity for people who haven't had babies yet, looking at employment opportunities for people with learning disability and autism. We will never reach that point. So our flow and our 100-day challenge are underpinned by nobody should wait in ED for more than 12 hours. No handover delays should occur. We should be able to have ambulance response times so that if you do fall over at the age of 85 and fracture your pelvis and 7 ribs, you don't stay on the floor for 16 hours. We get you into a place where you can be treated. And through doing this, we'll reduce harm through over-intervention, but also through intervention at the right time. So referral to treatment and elective care, which is planned care recovery. We're doing a really good job on that. We had a slow start, so our first quarter we didn't see the increases in activity that we needed to, but we're starting to see 104 days. We're nearly at 0, not quite, nearly. 78 days is looking good, and for people who don't do the weeks, 104 days is 2 years, 78 days is 18 months, which for anybody waiting for an operation is a long time. And in doing this, we want to reduce harm from waiting, because RCHT has a history of knowing what happens when people wait too long. And we know that it can have a significant impact on people's life outcomes as well as the way they live their lives. We need to develop intermediate care, because for Cornwall, that space between home and hospital doesn't really have structured supportive services in it. And in order for us to have a single point of access, it has to have services to refer people to that are there when people need them, not when we want to work. So again, there's going to be a big conversation with our workforce. We need to increase the use of our virtual wards, and if we're not going to increase the use of our virtual wards, we need to put something else in place, because there needs to be something other than a hospital bed to enable people to stay in their own homes. Our integrated area place-based care is amazing. We've appointed 3 managing directors who are GPs, so we've got clinical leadership at the heart of our new commissioning agenda. They will take money into place and they will recommission services. And at the point this will be with our organisations, but if we find we need different organisational structures, then we'll be asking those managing directors to make recommendations to the board on our behalf for our people. Palliation out of hospital. There isn't very much of it around Cornwall, and we know from data that I think this board has seen that 40% of people die in hospital when they'd rather not. I think a good society should be judged by how we treat our vulnerable and how we treat people who are dying. And on both fronts at the moment, we could do better, and our ambition has to be to do better. And increased reablement is part of that. I'm sure the board have seen the Peter Levin paper, I'm sure Mary and Steve have, that talks about how we get people out of hospital. And there's 3 case studies in there that break my heart. 78 up to 92, I think it is. People admitted to hospital overnight, staying 100 days. 2 people died and 1 person went into an institution. They all lived independently. So how do we have reablement at the front of what we do? We need to focus on our workforce and grow our own local workforce. I think Sarah Price, who was a board member here, used to talk about purple angels. No point looking for them when we can only find green ones. We have people in our system who don't have work. We have people in our system who don't think the NHS would value them as employees. So we need to find them, persuade them we're great, and start pulling them into careers in health and care. The anchor institutions start kicking in here. How do we make it possible for somebody with a learning disability or with autism to have a role in the NHS that's fulfilling. And by the way, it increases their life by 20 to 30 years. That should be part of what we do. We need to look at our apprenticeships. We've upskilled our current staff rather than using them as a way of pulling in new supply. And we do have an exciting opportunity this year that we're struggling with to bring 75 apprentices into place by November. And we've had our levy transfer from one of our commercial companies to enable us to do that. We're being invested in. And we need to develop and retain our existing workforce to be the best they can for the people they serve. And for this winter, I think we will be asking people to be very flexible about who they serve. Mental health, learning disability and autism, we need to respond to increased demand locally and to reduce waiting times. Waiting times for community mental health services are incredibly high. I think there's 400 people waiting for an assessment appointment. Right at the heart of that is tackling inequalities. Steve and I were on a call this morning where a man with a learning disability has waited 37 years to get his annual healthcare check. He's had it now. That is an inequality in action, because we know people with mental health and learning disabilities are way more likely to have long-term conditions and to die earlier from cancer that hasn't been diagnosed at a time when it could be surgically treated. We need to improve crisis. We've got one of the highest suicide rates per capita in the country, and part of that relates to the parts of our community that have got very unequal and very inequitable access to care and to opportunity in life. And then dementia. So both Steve and I share a very strong view that in our county, dementia is a diagnosis of exclusion. Once you've got it, there aren't services for you. But we also know that we over-label dementia. So I think we have around 85 people waiting for a level 3 bed at the moment. The first 15 have been reviewed and only 3 of them need a level 3 bed. The rest, we need to find a way to make sure their lives are the last bit of joy squeezed out of them, and that we make sure we care for the people that we've got. So there are priorities. We'll come on to the next slide, because we're not progressing these with the speed and rate that we need to. So from our system oversight meeting, and these are the RCHT specific challenges, we've all got them, and I'm going to send an email out to all colleagues later today around where I think we need to focus as individual members coming together in a collective, because that is all the integrated care system is, and all the integrated care board is a collection of determined people to be good enough for the people we serve. We need to get grip and control on our delivery plans. We haven't got them. We aren't able to do cause and effect monitoring in organisations and across the system. For RCH2, we need to implement the digital systems for managing flow, and in part those 3 people need to be in people's heads. They were admitted overnight, and then we take them on a journey through a hospital. Expected date of discharge needs to be in place so that we know whether we're hitting it or not. And criteria-led discharge needs to be in place, particularly over weekends. And I know great strides are being made towards this, but we just need to make sure that we get to the point of being able to do it in a routine and regular way. We need length of stay reduction. Some of this is around dynamic risk management. We are getting feedback as a system, which RCHT is part of, that we overprescribe the care that people need, and when they go home, shockingly, they sometimes cancel the care package they've been waiting 5 weeks to get. So we need to listen to what people ask for rather than give them what we think they should get. RCHT's engagement with admission avoidance schemes is really, really important, and Toby Slade used to talk about fit to admit. So the people that we're bringing into hospital, are they the people for whom RCHT, with your USP in this county, you are here for acute episodic care, for the times when the most vulnerable need you, whether they're having a baby or whether they're dying, whether they've got need chemotherapy or a hip replacement. You shouldn't be a proxy provider for services that other people should be providing. So we're going to take away our exec teams, and what I'd like people to talk about is what they do that nobody else can do, and then where we overlap with each other, because I think there's a real temptation we'll start trying to do other people's jobs rather than doing the jobs that we're here to do. And clinical leadership being all the way through that, and that's clinical leadership in the organisation, in all clinical disciplines, because we are going to have to ask our leaders to address the need of the population and to start looking at where we go to look after people rather than expecting them to come to us. So your specific challenges are supported by cross-system plans, and I think we are starting to get out of the all we've been criticised in the past as a system for being lovely to each other, but not holding to account and not driving the change that we need to see for our people. And I think as we get our cross-system plans together, particularly for this winter, we'll be able to say whether we are there to meet the needs of our 72,000 most vulnerable people. We know who they are, we know where they live, so there is no excuse for us not being there to be able to support them. Getting ready for winter, we're looking at some structural stuff. So 31 warm hubs, they are literally that. People will go there to keep warm, to be fed, to be make sure we can look after them. What do we need to provide at the 31 level? We have 15 primary care networks. What do we need to provide at a 15 level? We have 3 integrated care areas. What needs to be done 3 times? And for the things that need to be done once in RCHT and in CFT, how do we liberate you to be able to do the things that you need to do? And I think that would be as far as we've got in our first 60 days. So I thank you for your engagement, because I go back to the fact you're it too.
Thank you. So what I'll do is try and follow that, really. Ooh. I will try and follow that. Okay, so from an integrated care board perspective, I just want to endorse the fact, obviously, Mary, you sit on there, but as Kate mentioned, Steve, it's really important that everybody recognises that Steve, in your role as a fiduciary statutory partner member, you're representing the NHS provider, not just RCHT, and that's a personal challenge for you, but I'm sure you'll rise to that, but also a really important one, because you need to bring that voice of the collective into the Integrated Care Board. We've had one set-up meeting, as Kate said. We're only having our second board meeting on the 8th of September. Our papers will be out tomorrow. And I think it's important just to put the Integrated Care Board into the context of, also there is this thing that's called the Health and Wellbeing Boards. It is now the single Health and Wellbeing Board, because they've merged into one. And we've also got to try and get our draft Integrated Care Partnership Strategy together by Christmas. So it's no small task to have all that aligned, because the danger is we'll all end up with a multitude of strategies. So we've got to try and have a golden thread that feeds all this through together. From an integrated care board perspective, the kind of things that certainly from a scrutiny perspective we want to try and ensure that we're focused on is a little bit of language I just really want to labour to start with. To try and keep everybody on side, I'm going to use the language of citizen-focused. Are we really citizen-focused? How are they engaged in service redesign? Each of the touch points they actually have with us across the entire system, not just either RCHT or CFT or the NHS, but the entire system as we do that. So citizen-focused. To really think and reflect on, are we clinically led across the entire system? And I think that's again about clinical and practitioner engagement in how we do that. Are we truly evidence-based? And I think we've just got to make sure that we have evidence bringing right the way through at place and community and at county level that helps us shape our decisions. It can't have missed anyone's attention that we have to have a balanced budget while we're performing. So that's something that we also have to think about we're doing. Driving out health inequalities across our county. It's not equal across everywhere, and we have to make sure that resources are focused. So driving out health inequalities and being place and community based, how are we doing that? So some of those thoughts are still in the process of being developed. You might think, well, you had plenty of time to actually get this ready for the 1st of July. Well, we could have been, but we had a whole group of new executives joining us under Kate. We've actually got a whole new partnership board that's come together under the Integrated Care Board. It would be rather presumptuous to say we've sorted it all, no, please run with it. So we're actually taking forward, these were the initial starter for 10 ways we set ourselves up. We've actually got a review going on in terms of our governance that we'll bring probably to the Integrated Care Board with everyone's engagement in November. Almost I think the first thing that Kate did as Chief Executive was to kick off, which we announced on our, I think it was either the 1st of July board meeting or the 14th, I can't quite remember where we announced it, but the PRISM piece of work to actually look at how we were doing in terms of flow and discharge that will help inform us. Because I think one of the things that we need to do as a group, working collectively, is we don't need to be defensive. I don't think any individual organisation has the answer on their own. I think the answer probably lies in how we look again at how we do this at a total perspective. What that means is, and that's why Kate and I were so pleased about the way in which the True North piece of work went, we were able to align behind our vision, a collective aim, our top 6 priorities. And some of these things are of our making, and some of these things we're being encouraged to focus on. And I'm thinking now of the 63 metrics for the National Oversight Framework. I'm not so sure if I'd have started the day, I would have started with thinking 63 is the answer, but we have to do that as well, as long as us focusing on our statutory goals on top of that. So we've got lots of things to focus on. So one of the things that I think we've got to do as an integrated group is as Kate shared on the slide deck, is those 6 priorities. Have we set them up to succeed? Have they got the right groups of people around them? Have they got the right mandate? Are they clear on how it works across all the providers, not just the NHS providers? And how are the third sector and the councils engaged in all this? And care homes, for that matter, and SWAST and the whole group, how are they all engaged in those new models of care? And I think the thing that we should all be ambitious today is being ambitious. Let's think about how we're going to shift the dial. At board level, it's very easy to get sucked into business as usual and 1,000 KPIs. And certainly at integrated care board level, I would encourage us all to think about those fewer things at strategic level, while recognising we are accountable for the 1.2 billion and the outcomes that come from all of this, is how do we collectively exercise our duties to make sure that we're shifting the dial. And certainly for colleagues who will start to see on the Integrated Care Board, the new agendas that are coming out and the new forward plan that's coming out, we're going to try and encourage ourselves to be focused on the things that are shifting the dial, allow ourselves to set up the programme boards of the new genre based on what we have now, because it's gone well. But there is more that we can do, and there's more that we can do to shift the dial. So Kate will lead that piece of work in terms of how that planning will come together to help shift the dial. Sharing resources. We're a small system. There's a time when I think it's small is easy, and I wish I was in London or Manchester, and there's a time I think I wish I was in Cornwall, which I am, because sometimes it is easier. But there are times when we need to reflect on, we have now got providers, we have now got a system chief executive, we now have a system CMO, CNO, CFO, etc. We shouldn't be trying to do each other's jobs. We should be trying to work out how we do things that are complementary between us all. And therefore there'll be times when the natural tendency is, let's go and recruit X or recruit Y. And I think we ought to get ourselves together and say, what if this is one system, what would we have as one way of doing things? We probably all have to respect, we all need one CFO probably, each. But everything else for me, other than what's in the legislation, is what works. And therefore I think we should enter our system approach for what works as opposed to what works for a particular organisation. I'm sorry if that seems challenging, but I think that's the system, the way we've got to do this. I'm encouraging everybody to think about how we bring the third sector into the room. If we're going to be truly place-based and we can push things down to community level, there's got to be things that are better done at place, at home and community level than probably we can deliver. And therefore, how are we going to do that is important, and we talk that through. We've put the infrastructure, we hope, in place to start to think about doing that. And we need to think also about, therefore, what are those services that can go down to them? There'll be things that we're going to do, Steve, that are going to be county-wide. There's no two ways about it. But there'll be times when we need to think about what are those things that we can empower place to decide, and who do they commission, etc. And for that to actually be a collective decision in how we go about deciding what is county-wide. And that's where the citizen input needs to be mirrored with the clinical input to be able to take that forward. And that's why things like the Clinical Prioritisation Advisory Group, the Clinical Executive, a revisiting of the citizen panel will have to take place, because we have to ask ourselves, not critically looking back, was it wrong, but is it fit for purpose going forward to really maximise what we want to do going forward. I think, Steve, you raised in your earlier point, I was listening in, I wholeheartedly agree about risk sharing across the system. There's no value in one team actually having a risk profile of X if another team's actually got it as Y. Let's share risk, let's decide what that is and actually focus on those elements. So I'll finish off looking at the clock, Chair, by saying this. There's something for me about not looking back and being defensive in going forward. I think it's about looking forward and working out how, with the resources and competencies and capacities and accountabilities we've got, how do we leverage those to really shift the dial and do things better on behalf of those we serve.
Thank you, John, and thank you, Kate. I think you've done remarkably to cram an awful lot into a relatively short time. We have got about 5 minutes. I think it's important enough for us to run over a little tiny bit if we need to. I really, as I said, value you having come today. Part of the value in you being here and in having this item at our board is for members of the public to understand what it is that we're all talking about, because people don't entirely, and most members of the public think the health service is the health service, and so why are we making all this fuss about different things? What we know is that we have been segregated and separate, and it's actually really important that we find ways of just becoming the health service again. So I'm going to take questions. I'm happy to let it run a tiny bit over. Steve, I know John has given you a great big role there in being responsible for everybody and everything that moves in terms of providers. You may want to just add a couple of remarks, and then colleagues, happy to take your questions. Thanks, Steve.
Yeah, I'll be very brief so other board members got the opportunity to comment. Firstly, it's really, really positive, John and Kate, to have you at the board, and I'm sure this will be just the first of many discussions in a public board setting to complement the discussions that happen elsewhere. The Integrated Care Board is critically important at any point, but if you think of the kind of challenges that you've both touched on, the extraordinary financial challenges being faced across the system as a result of energy inflation particularly. I've mentioned the sustainability risk that provides immediately to providers, but of course the health impact to citizens that Kate touched on is significant. So all of that to me is absolutely reinforcing the importance of integrating, of working together, of collaborating, and of putting aside traditional organisational or clinical barriers to work together. They're exceptional challenges, but I'm struck, John, by the ambition. And I think we can use those challenges to accelerate the changes that we know are possible. So there is an opportunity for us to use that as an accelerating factor. Just really, really briefly, we are an acute provider, but the opportunity to deliver care close to home is really significant. So the work we're doing with the community partner, Cornwall Partnerships Foundation Trust, and with ICB executive colleagues around the opportunities like Bodmin to create an elective centre at Bodmin, so colleagues, citizens don't have to travel to Plymouth or Trelisk is really significant. And if I think of the opportunities to look at transformation to deliver acute care on the Isles of Scilly, in a way that those things can transform lives and access to care. So it is really, really important to us that we are absolutely embedded as part of that. The other observation, of course, is as an acute provider, it's critically important that we work with other acute providers, and the peninsular collaboration of the acute trusts is particularly important to sustain acute care in Cornwall as well. So the partnerships that we're building with university hospitals, Plymouth, with Devon and Torbay particularly, are an important part of how we can realise the vision of more services close to home from an acute hospital perspective as well. So that peninsular layer is a significant, important factor for us as well. But Mary, I'm really keen to hear comments and questions from board members.
Thank you, Steve. So, colleagues, there's been a lot there, but it's been well heralded. So are there comments, thoughts or queries? Sarah, you've got your hand up first, so let's hear from Sarah Newton first. Thank you.
So thank you very much. It's fantastic to hear your passion and your ambition. I'm sure it's something we all share, and are very positive about being able to work together and breaking out of our silos. There's probably a lot more I could say about that, but I'm not. I think it's just we all agree with what you're trying to do. But thinking about the here and now, the winter we face, the challenges we particularly face, we know that we've got a particular problem in the county with our social care workforce. And while really wanting to support enabling people for which it's the right place for them to be at home and to receive their support at home rather than come into the acute trust, what will you be enabling the system, as all part of the system, to do this winter, which is different than last winter, to be able to build that capacity to enable people to be at home, or if they do come into the trust, to go home or to an appropriate care setting?
So
So first of all, it's not a social work workforce, is it? I think there's 14% registered nurse vacancies in RCHT with a 9% vacancy rate overall. So for the county, and I think it's a similar vacancy level in CFT. So workforce is an issue for everybody in the county, not just the local authority. So how we work together, and I suppose my other thought is the workforce we've got is what we'll have, and the people we've got in county will be the ones that we'll have. I think we've been distracted by how we bring people in. We know there's no houses. We know that inward flow of staff is difficult. So if there are truths, I'd be looking to some of my workforce colleagues, so to Alison and to Patrick, to start looking at how we are stimulating supply, to look at some of the rules that we've got about who works in health and who doesn't, in terms of pulling in parts of our community that we could offer roles to. And we also need to look at how we deploy the staff we've got. So I think many of you will remember when we had the planning for COVID, and Susan Bracefield and Robin with our clinical directors came up with a 4-stage plan to basically get everything into intensive care if it needed to be. We need a similar plan for care outside of institutions that starts to look at patient to staff ratios that are the equivalent of what the 1:4, 1:8 would have been in intensive care. So we have to plan in the reality we've got, not the one that we'd like. And I think there's a People's Board this afternoon where Patrick will be taking that challenge to our HR colleagues. And as a slight aside, but it's only a slight aside, Susan Bracefield and Helen Skinner are looking at setting up a professional standards unit, because some of the ways in which our colleagues are working in Cornwall doesn't reflect the standards and practices of their professional colleagues, particularly around reablement and admission avoidance. So we need to remind people what good looks like. We need to let them know that we have their backs for doing the right things, and then we need to rely on everybody in Cornwall to do the jobs they're there to do, and to hold each other to account for that. Now that's not I haven't seen your winter plan, so I don't know how much of that plays into your winter plan, but we have to bring as much into people's homes as possible, because hospitals could well become vectors of disease over the winter, and we don't want people contracting things while they're waiting for something else. We want them at home as safe as possible.
Oh, it's still on, I think. So clearly all parts of the NHS have got staff vacancies, and that is well understood. However, the independent assessment of the challenges that we face in Cornwall particularly highlights the social care workforce. And so what I would love to see, as I know you love to do this, Kate, is some real innovative thinking about how we can bring forward and engage and encourage people into what is actually can be a very lovely and wonderful and satisfying job. So I do think there is more to be done, accepting that we have our challenges and some of our staff could be used differently. And RCHT, I know last winter we had staff going into residential care homes, and we still have a lot of our staff going out into the sector to support the sector from, frankly, trying to prevent residential care homes, which are on the brink right now in Cornwall, from closing. So we have a good track record, and we will want to continue to do that. But in the spirit of wanting the one truth, so that we can all work together, I think we should engage with the independent data that has been given to us, which shows a particular problem.
So we're talking about the CQC, and this comes up all the time from RCHT. I'm really sorry. So in terms of the steps that the council is taking around their statutory responsibilities for the people that they serve along with us, they are doing the work that we've asked them to do. Now, nobody around this table, and we have very experienced people around the table who'll understand doing a capacity plan for domiciliary care changes on a daily basis according to whether people have handed care back or not, whether somebody's paid for their own, whether somebody's come out of a hospital. So we are asking social care for a level of accountability we don't provide ourselves. So we will pick this up as an integrated care board, but my message to RCHT is you are part of this. What I hear is RCHT holding our local authority to account a lot, and we need to work with them to help them deliver the care for our people. It's amazing that we've been redeploying our nurses. I was thinking more about our therapists. I was thinking about things that we can stop doing during 2022-23 winter. So we will come back to it, but I just want to be really clear, the whole of this system is orientated on what we need to do, and that includes the local authority.
Thank you, Sarah, and thank you, Kate. And it does pick up the point about we are all accountable to each other, aren't we? And we need to feel that we are. John, I know you indicated to come back to Sarah. I have got two speakers waiting. Is yours specifically on the point of Sarah's, or can I?
Yeah, it was on that.
Okay, briefly, if you can, please.
I'll be 30 seconds. So everyone can do better. We have a vacancy in the NHS, as you know. It's interesting that we meet with the senior players from the Department for Work and Pensions and job centres. And you know, I said earlier on about being citizen focused. Have you actually ever thought about applying for one of our own jobs in the NHS? Because when our job centre colleagues say to us, do you know what, when somebody out there in the front looking for a job and they try to go to the NHS, look at the number of hoops that you have to go through. Do you know what, I'm off to Tesco's. We can do much better to fill our own vacancies without even thinking about elsewhere.
Thank you, John. Helpful contribution, and I too have heard that. So I think the whole of the NHS could do better, couldn't we? And I know we've got HR colleagues here who are really working on that at the moment. I've got Richard first, and then Kelvin, and then I will take one more, but we really do need to wrap up shortly. So Richard, and then Kelvin.
Thank you, and I appreciate the time constraint. So I'll just make a comment. First of all, really was just in the priorities. I think it's explicit in everything you've said in an ambitious and hugely exciting agenda, but perhaps we should be calling out a priority for health inequalities and actually putting it front and centre in one of our priorities. It's, as I say, it's implicit in everything you've talked about and explicit at times, but it's probably one of the single factors for the long term. And as Steve's alluded to and others, some of the socio-economic factors are going to increase over the foreseeable future. I suppose my question then went back to, and Steve's touched upon it in his presentation bit, really around the system interface. We're not a closed system, we're an open system, and we are dependent on other areas of other systems across the peninsula. And I wonder if you could just say something about how we're interfacing with those systems in order to make it as seamless as possible, to make sure our priorities are aligned, our strategies aligned, and to make sure that as we work as an acute provider across a wider system, we aren't in conflict.
Thank you. Can I take Kelvin's question as well and then ask you to respond to both? Thank you.
Okay, thanks. Yeah, Kate, really interested in the warm hubs concept because I've been part of a working group where, working with council colleagues, third sector colleagues, we were looking at how we can provide digital support in a community hub. But as a group, we worked out quite quickly there has to be a really important reason why people would want to go to the hub. And I think with the warm hubs, we've cracked that. So really keen to talk to the team organising that so that we can actually then put in some digital and digital inclusion support services for anybody coming along to the hubs to help them through the winter off from that point of view as well.
Thank you very much for both questions. I don't know whether Kate, and if you'd be kind enough to be succinct, thank you.
So thank you, Kelvin. It's a fab offer, and the 31 hubs are being set up by Volunteer Cornwall with the local authority, the voluntary sector organisations, of which we have 5,726 in the Cornwall and the Isles of Scilly, are wrapping around each of those warm centres. So Richard, this is our inequalities step into winter. So we're placing those hubs where we know we will have the greatest inequalities, and we do know from our population health data there's 72,000 people at risk before the cost of living increases, so that will be even higher now. And I am hopeful that through the warm hubs we'll actually notice if somebody doesn't turn up one day, and we might go and find them before they become poorly in their own homes. I should have said the 6 priorities are underpinned by a digital platform which Kelvin is leading for all of us remarkably brilliantly. Inequalities in health, and I've forgotten what the third one is, but there is a third one. So we are making sure that we follow the KPMG advice. Focus on your population, digitise everything, and then you are most likely to be able to deliver the changes you want to see. In terms of acute care interface, so we have I think a strategy for Cornwall for all of our services that needs to be restated. We know that as Cornwall, Royal Cornwall Hospitals is a large acute trust, but that the specialised services flow primarily into Plymouth and beyond to Bristol for specialised children, although that's starting to be repatriated. So the Peninsula is going to come up with a clinical services strategy, which will involve RCHT, UHP, RD&E and Barnstable. But we also then need to work out what that means. So we have collaboratives for radiotherapy, we have an alliance for cancer, we have the cardiac networks. They effectively are collaboratives. So we need to make sure how that collaborative infrastructure is delivering. So we're round the table with the ICB for Devon. I'm part of the ICB board. Joan Milligan's part of our board. That includes all of our development days. We are advocating for the Cornish population so that we keep the services that we require to run our A&E department, because there are some things, if we take them out, we won't have a functional unit. So we just need to make sure that we are building on what we've got in Cornwall, not reducing it. And also we need to work really closely with Plymouth, because for all of us, that's where we'll go if we've got a specialised condition, and we need them to be brilliant. So we're part of their system oversight meetings and part of their engagement with the regulators.
Thank you, Kate. I'm going to let John have 30 seconds and then we'll wrap this up.
Yeah, 30 seconds. So answer Richard's question also in terms of out of county, how we're all working. So there's 42 integrated care boards. The chairs and chief execs at national level with NHS England chat and meet on a regular basis, directly right the way through to NHS chief exec and COO. There are 7 ICBs and ICSs within the Southwest region. As chairs and chief execs under the regional envelope, we meet regularly and chat regularly. Kate mentioned that on our board we have the Devon chief exec. We did I had the conversation with the Devon, my opposite number, and in fact Kate sits on their board as well. So at a Peninsula level we have everybody sitting on everything, and I think it's just fair to say it's all got to be worked through, because we can't crack. There'll be certain things we can crack in county, there'll be certain things for the quarter of our population that go to Devon for their answer, and there'll be certain times when regional and national are part of the answer, and we're plugged into all of them.
Thank you, John. I really appreciate your brevity. So in wrapping this up, can I thank you both very much for coming, and can I note that what NHS boards do is we have difficult discussions in public, and so we should, because that's our transparency. But I guess I'd like to emphasise, although there are things that we need to work out between us, as you said, Kate, it's very early days, and this board, I know everyone will endorse this, is absolutely committed to being actually us being the ICS, because as you say, Kate, we are. And so I'm sure that we can go forward, and I think it's a strong team that can have some discussions and differences, and so that we get to the right solutions. And we're all here for the people of Cornwall, and that is what I know this board is signed up to. So can I thank you very much for being here. I'm sure you'll come again, and we'll come talk to you as well.
Pleasure.
Thank you very much indeed. Okay, board, would you be kind enough to allow me to vary the agenda just a little bit? I have got, Kim, your permission, thank you. I'm going to bring item 10 in front of item 9 because John is with us and we don't want to hold up our clinicians ever. And so if we could come to the what we asked to do. Just note the presentation. Apologies, I keep doing that. But John, if we could come to you and take your Guardian Safe Working Hours quarterly report, please. And people are being given prizes for brevity of presentation. We can't hear you, John, sorry.
Can you hear me now? Yep, you can hear me?
Yes, thanks, John.
Okay, there's a number of things I want to bring up in this report. Usually, the quarter 1 report is a very straightforward affair because it takes the last few months of the training year of the junior doctors. There's hardly any exception reports, and we've resolved most of the issues of the year. This year it wasn't quite the same, and I draw your attention to table 10.1 and the graph following that. Since we have been monitoring exception reports, we had a general decline through the years. That's been reversed from activity in the last year. The exception reports that were issued in the quarter that I'm referring to is nearly all related to staff sickness related to COVID. Additional working areas such as the AMU and ED. So each and every exception report was reasonable, justified and entirely appropriate. And we do encourage our junior doctors to exception report. I don't think we have to look at the additional number of exception reports as evidence of a failure or anything like that. It's evidence that this hospital and the junior doctors are out of shape and working differently to their intended work schedule. And that's entirely appropriate given the challenges that we faced. It is nice to know that there's one ambulance outside ED this morning rather than what we've had before. And that impacts so much on the hearts and minds of junior doctors to work in the environment where patients aren't in the right place and doing your best to try and deliver good care when we have not got the resources to deal with what we had, does lead to unhappiness amongst the junior doctors, and that normally comes through in exception reports. If we can try and restore some sort of control over everything, and the ambulance is a really good barometer of that, people, junior doctors, start getting more comfortable with what they're doing. Seen from the latest workforce survey that sickness is reducing fast. So hopefully a lot of those challenges that we experienced in the last year of the junior doctors is something that's going to diminish. At least we're hopeful anyway. I'd like to draw your attention to the vacancies. Now, vacancies have been a success story very much so over the last number of years. And although HEE regularly are unable to fill 20 to 30, sometimes more posts, we have a process to fill these posts with clinical fellows or trust doctors. I was surprised to get the figures for August showing that we're back to 21 vacancies. 5 of these are from expanded posts, but this is a real setback on where we were going. Now, vacancies cause a problem for junior doctors. Vacancies mean that holiday can't be taken when they need to and want to. It means study leave can't be taken when they want to. Vacancies mean the junior doctor's exception report. So these vacancies are significant, and we need to do a little bit more work in understanding exactly what a vacancy means. Now, the reason why I say that is back in the day, every doctor's post was filled by a doctor from HEE, whereas our workforce has evolved over these last few years to include international medical graduates, physicians associates, medical support workers. So there are a lot of people that their presence doesn't stop a vacancy still being declared. And I think we're at the point now that we really need to reconsider how we review our workforce, the junior doctors, and what we declare as vacancies, because I don't believe there are 26 holes, 21 holes in the medical rota. I believe that some of them are filled with some of these associate colleagues that now work for us. That being said, we have an increasing population of less than full-time colleagues who work with us. And from the junior doctor's point of view, more than 10% of our workforce do not work a traditional full-time. There are 41 junior doctors, and if we included the GPs trainees that work in the hospital, that's 53 junior doctors who are working less than full-time. And as you can imagine, the reasons to work less than full-time, we tend to see this in the registrar years, in the more advanced training roles. So we really need to almost start thinking of full-time equivalents and how we're going to deal with that. And as I step down from The Guardian at the end of this month, it's my plan to work with the medical division where I work to evaluate the workforce in more detail, because I think we can be a bit more clever in understanding our workforce needs, our vacancies, anticipating holes going forward. I'm happy to take questions at the end. Just two other quick points. There has been one immediate safety concern. Although it doesn't strictly fulfill the terms, there was one shift that we didn't have an entirely adequate cardiac arrest team because somebody was moved from that team into another area. And we did not take steps to replace that person on the cardiac arrest team for that shift. During that shift, there wasn't a cardiac arrest. It wasn't turned out to be relevant, but there are lessons to be learned from that activity, and that they have been addressed. The final point is I've been mentioning it for years, but I can tell you now that the fire doors are virtually being screwed on as we speak to the junior doctors' rest facilities. And as soon as those fire doors are on, they can be redecorated, and these rest facilities that we've been waiting years to have are about to go online. So that's all imminent. Other than that, I'm happy to take questions, but that is my final report.
John, thank you so much. I want to comment on it being your final report in a moment. I have 2 or 3 questions and would invite comments if they would like to raise any matters. But perhaps before I do, I celebrate with you what you've ended on around the rest facilities. It was one of my questions. I thought you charmingly put before too long in your report, and I wanted to know how long before too long was. But I think you've given me the answer, so it is to be celebrated, because like you, I've been waiting for years for that. Colleagues, are there questions that anybody would like to put to John? Jill. Go.
I think, John, it's beholden to me to say thank you for your term of office as Guardian of Safe Working, and you were the inaugural Guardian, I think, weren't you? Because it was a new role to reflect the support required for junior doctors when their new contract was agreed. And I think it's, you know, since I've been working here and working with you, I think you've just created such a strong foundation for your successor, Sarah Coulter, and just the right style of warm, compassionate leadership, but a firm, fair and pragmatic approach to some of the junior doctors' challenges and issues. So thank you from the Medical Director's Office. Really appreciate all that you've done. And as I say, your worthy successor, Sarah Coulter, will have a hard act to follow. So thank you.
Thank you very much, Jill. I've got Alison and then Robin. You're muted, Alison.
Am I okay?
You are to me.
Thank you. I was just going to echo Jill's thanks with the work that you've done with people and OD colleagues, John. And I know we haven't known each other very long, but I just wanted to thank you for the collaborative working that has happened, and also echo the support to your thoughts on that we need to be a lot more creative about how we review our vacancies in the future. Thank you.
Thanks, Alison. Robin.
Thank you. I just want to start by saying thank you, John, for some really robust challenge conversations we've had together. I mean that really sincerely. I've really enjoyed working with you in that regard. What I actually wanted to pick up on was the point you make around, as the ambulance holds reduce and we right-size our hospital for this moment in time, the benefit for all our staff groups, junior doctors, consultants, therapists, nurses, admin teams, it is massive and shouldn't be underestimated. I think it's an opportunity to say thank you to all of our teams for the stretch that they've undertaken when we've been under those really significant pressures. So thank you for highlighting that, John.
Thank you, Robin. Is there anybody else with any questions? So if I could just add to what you've said, Alison, I think it would be a real credit to John if we genuinely did review the way we describe our vacancies and the way we describe the different patterns of working that people are wanting to adopt. So I really endorse what you've said, John, and what you said, Alison. I'd then like to endorse what colleagues have just said to you, John. When you and I first met each other, I hadn't got a clue what a guardian of safe working hours was, let alone a report or why or how it mattered. And some of the F1s and F2s just foxed me. I hadn't got a clue what it was about. And it's been such a pleasure to work with you, John. You've really helped me to understand the value of the role you do and actually what you do for our doctors. And in both what Alison, Jill and Robin have said, it really is your style, I think, that makes this so successful. It isn't what you say, it's the way that you say it and the way that you do it. And I really think it's a pleasure to have been working with you. I do remember a very early meeting, John, when our room in here was up round the other way and you were sitting sort of over towards the window, and I think I was a bit challenging, and I think you didn't understand why, because I didn't know what I was talking about and you did, and you were so polite and so really lovely and helpful. And so my own experience bears out what I've heard colleagues say. I can only thank you very much on behalf of the board. I'm glad you're not going away altogether, and I know you will be supportive of your colleague coming in. You told us that last time that you were with us. So in thanking you very much, can I also welcome Sarah Coulter and say we just look forward to this going on getting better. And I'm very tempted, now that I'm allowed to be on site, to come and look at these restrooms that we've taken so long to get. So thank you very much indeed, John.
Thank you very much. I'd like to say that although I'm the front of being a guardian, as everything that we do out of the postgraduate centre, it's very much a team effort, and most of my decision making has gone through and been guided by Jill, who has been an immense support during my time here. So particular thanks to Jill, the junior doctors committees, and the postgraduate centre. And I've started some other work with Alison, trying to make consultant lives better, which we'll pick up on, and we'll do those other vacancy things as well. So I'm not going away. I'm still planning to change a few things in this hospital before I leave. But thank you very much.
Thanks, John. And as ever, you're very welcome to stay for the rest of the meeting. I'm sure you'd love to. Board, we're asked to note and have discussed the quarter-run report from The Guardian, Safe Working Hours, and if we could also note our great thanks to you, John, and your team. So, Kim, if I could then come back to item 9, the maternity safety report, and thank you for giving way to John on that occasion.
Thank you, Chair. So this report has been robustly discussed at QAC, which is our Quality Assurance Committee, and I know will form part of the Chair, Ruth Allerton's report. I'm going to take it as read, but just highlight a few key points. There was one patient safety incident investigation in the month of July. This will have Healthcare Safety Investigation Branch, which is a national organisation investigation, which is in line with national policy. It will also be locally reviewed at the Perinatal Mortality Review Committee using the tool. We've been requested not to do any further investigation, which is in line with the national ask, and our sympathies go out to the family concerned. There is no immediate actions or learning to be taken at the moment, which is important to note. There was 0 maternal deaths and the 1 stillbirth, which is highlighted and I've discussed above. Really important to note that 1 Datex was written on behalf of a staff member who had some skin irritation from a mask. So we're still being very, very careful and giving that occupational health support as required. We are currently being measured against Occident 1 because we now have Occident 1 and Occident 2 with various criteria. It's important to note that we have 0 non-compliant actions currently, and against Occident 2 we have 4, 2 are national and 2 are regional, which we'll need further guidance on. As a trust, we absolutely recognise the importance of both, and we're running both in parallel to make sure that we don't miss any learning opportunities. Really important to note that with good intent, appraisals are still at 49%. The team worked hard to give the 10% increase, but due to much short-term sickness and absence during the month, this wasn't achieved. However, with some learning, we've now got some midwives, senior midwives updated, who will be able to upload those appraisals once done immediately. So we look forward to that progress. I'm not going to cover CNST because that will be coming to board in full in September. Staffing remains challenging, and we're really looking forward to welcoming 12 new registered midwives in the month of September, which is really exciting, with the appropriate additional support from the senior specialist teams as well, recognising that like the nurses that are coming out, it has been a very, very different healthcare scenario over these past 3 years. As I've said, in the last 2 months, our maternity continuity of care has paused. However, we are providing that to the most vulnerable in our society. We are not alone. It is a national picture whilst we get our staffing levels up to safe staffing levels. However, what we have started in the acute hospital with the support of the midwives is that 3-month rotation programme to start making sure that we will be ready to progress with the continuity of care plan when ready. It's really important to note that I noted the training in our anaesthetic colleagues was really low for the last 2 months. Really pleased that the consultants have raised to 89%. Anaesthetic doctors looks a little low at 47%, but all of them have their training booked for September and October. And of course, we've got Sarah in the room today, who's our non-executive colleague, and she continues to support and has been active in the governance meetings as well as the local network meetings, which is really important. And I'll rest it there.
Kim, thank you very much, and again thank you for a very helpful report. I think something that's nice about seeing these reports is that you do see the gradual build up and build on of improvements that have been made. Very briefly, before coming to anybody else's questions, is there any comment that either Sarah or Ruth would like to make? Isabel, I'll bring you in a second. Sarah, do you want to comment at all?
Nothing to add, Chair.
Nothing to add. Thank you very much. Ruth, did you want to add anything from QAC? Quality Assurance Committee.
Yeah, thank you, Mari. Only to add that we are also talking about how we best look at the report that comes to Quality Assurance Committee and to board, so that we get assurance for the board at Quality Assurance Committee, and then board can see what we've discussed.
you, Ruth. A very helpful point. Isabel.
Thank you, Mary. It was just a congratulations for all the hard work that's been going on in this area. I'm starting to learn a little bit more about it of recent times. But I just wondered, Kim, whether there is any benchmarking undertaken in terms of Ockenden so that we can see how we compare within the region and also nationally in terms of the progress that has been made. You know, and as I say, congratulations on all the hard work.
Thanks, Isabel. Kim?
Yeah, there's absolute regional as well as national scrutiny and benchmarking against the key performance indicators, Isabel, and we're faring well in the southwest region, which is really important to note. And we had the Chief Midwifery Officer for England visit with her senior team, Alibi virtually, where that was discussed with Steve, myself and the senior maternity team. We are not on the worry list, but we're working really, really hard to be able to maintain that position, and staffing, like everyone, is the constant challenge.
If I may, Chair, is that information that will come to the Quality Assurance Committee?
Okay, Isabel, did you want to speak more?
Can you hear me?
Yes.
Yeah. Sorry, yes, I just wanted to know whether that benchmarking data will be part of what comes to the Quality Assurance Committee.
Isabella, yes, it will. It comes out quarterly, so we'll make sure that it's encompassed as we get it.
Thank you very much.
Sorry, are there further questions on item 9? In which case, Kim, I think we congratulate you again, not only for the work, but for such a comprehensive report that has obviously answered people's questions. We're asked to note the updated position against the Ockenden report and note the changes to the midwifery models of care. Which then brings us to item 11, and we are behind time, for which I do apologise, although I think it was important that we gave our ICB colleagues some time. So I would like, Robin, if it's okay, to take this item, and then we will take a break for lunch. We may have to shave a moment or two off lunch. And perhaps, Robin, if I could, before starting, just note that people may not be as aware as perhaps we all should be that a lot of these performance issues that we see in the Integrated Performance Report are brought to our committees, the People and Organisation Development Committee, the Finance and Performance Committee, and the Quality and Assurance Committee. And it is important for us to know as a board that those committees do some of the work that particularly pertains to this report. In future, we are going to be looking to see whether we can hear a little bit more from our committee chair colleagues, as well as our report of the activities of the committee, because I think it's really good for us as a board to hear the assurance from the committee chair that you have indeed either had assurance or that there are risks you want to bring to our attention. So I guess just as a prelude to what you're going to say, to note that these matters have been considered. Thanks, Robin.
Thank you, Chair. You're quite right. Quality Assurance Committee and Finance and Performance Committee robustly reviewed these reports, so we will do highlights now to leave time for plenty of questions. So I think the best way round then is if I make are you ready, Kim, to make a start, or do you want me to do for performance bits? Anything for you to highlight from the Integrated Performance Report?
Yep, so important to highlight that we, on page 120, we had one never event in the month of July, and that was in regards to a retained guide wire in our intensive care unit, and that's currently under a patient safety incident investigation, and I will keep people posted. Some immediate learning was taken from that and instigated, but it's still under investigation. The only other point I would probably raise is on page 122, duty of candour was at 47%. Now, this is because of the sheer volume, because of the COVID and the openness and transparency and following our duty of candour. As of today, that is now up to 80%, which has left us 7 out of 36 cases to finalise. So that shows the team are working on it, but it is about having that time and opportunity to have the discussion with both patients and family. It's no surprise that our planned versus actual, so planned for registered nurses is what we plan to have on duty, against what actually happened, still remains at 86.2 for trained and 81.49. So in spite of best efforts, we've had a very, very challenging period, and we're working hard with our collaborative bank to make sure that we cover those. And I'll leave it there.
Thank you very much, Kim. If I turn to Jill from a Medical Director's Office perspective.
Yes, I think the key highlights are obviously our ongoing concerns around mortality. Our crude mortality is sort of plateauing, which is obviously the most up-to-date indicator. We know nationally it's a similar. There's been a similar rise in crude mortality. What's more concerning is the ratios between our mortality and other hospitals in similar situations, and so we, in terms of the HSMR and the SHME, if you like, which are compared against other organisations, they're a little bit behind in terms of the reporting. So this is data from April and May, but is under ongoing scrutiny. And we do know that we have some particular hotspot areas in terms of stroke, fractured neck ischemia, and other areas, and some of this is as a consequence of our operational pressures and delays for fractured neck ischemia getting into theatre, and delays for our stroke patients getting into the right place. And there are in-depth action plans for each of those areas that the teams are working on. And the other aspect is and we mentioned it briefly at the beginning of the meeting, the sepsis audits, and we look at sepsis and response to patients who have been diagnosed with sepsis in ED and across the wider trust. We have a lead nurse for sepsis who is doing some amazing improvement work. And we've already mentioned the Royal College, Academy of Royal College's guidance about changing guidance for sepsis. So it's making the analysis of our response to sepsis a little bit more complex in terms of should it be within 1 hour or 3 hours for antibiotics, and the use of our electronic systems to be able to track that closely. But there is still a lot of improvement to be made in documenting the safe and timely response to patients who are at risk of sepsis. Thank you.
Thank you, Jill. Steve's update has already covered off the 104-week position for us. I'll draw the board's attention to the cancer performance on page 104 of your packs. The point really to highlight here is the breast position, and what we're doing as a whole system now is with Susan Bracefield we are arranging a full system meeting to review what further actions can be taken in terms of capacity and demand management to attempt to make a difference to the inbound demand we have for breast imaging against the capacity that we do have, and we will be sharing openly with our colleagues the actions that we're taking to boost our breast imaging capacity within the trust. But this now needs a whole system approach to tackle that challenge. You'll see in the report itself it also talks about some pathway changes being undertaken in some of the other tumour sites, which is implementing some best practice, which will see further improvements on those standards. And new information wasn't available for the Finance and Performance Committee is we're updating our RTT referral to treatment meetings. They happen weekly to bring further support to our tumour sites from a cancer perspective, which we know in the past has seen further improvements in that delivery. I draw the board's attention to stroke, page 102. This is being impacted on our capacity in the stroke unit. We don't have medical outliers in the stroke unit anymore. We are achieving that ring fencing, but we are seeing stroke patients having slightly longer lengths of stay, and therefore we're effectively running out of capacity to admit new stroke patients to the stroke unit, and then we know that then knocks onto our other indicators. We've talked on Steve's update on boarding. We do board, so that's additional spaces. We do board in the stroke unit, but only for stroke patients. So there are some spaces allocated to try and alleviate that pressure. And Bernie George is leading the weekly review sessions from a stroke perspective to make sure that we have really senior oversight on the actions that we are taking for stroke recovery. And then my final piece to draw to colleagues' attention is on page 97, the ambulance delays are marginally down, but not significant at this time, in the interest of honesty. We are having a better week this week. I can say right now we have no ambulances out at the front of the hospital, so the teams are absolutely driving hard on those initiatives. But I'd like to particularly draw to your attention that we are seeing an increase, and again on page 97, on patients leaving the department before being seen. And what we're doing is we're pulling that through into our Flow In programme. The clinical lead for that bit of the programme is Toby Slade, and we're doing some deep dive analysis as to what's driving that. Is there a change that we need to make accordingly? So in the interest of being speedy to give most time for questions and noting that big debates in the two committees, we will pause for questions now, Chair.
Robin, I think so far you get the prize there, so thank you for being succinct. I have 2 or 3 points I just want to comment on, but colleagues, are there questions that you'd like to put to any of the colleagues who've spoken already? Okay, well, maybe while you're thinking, I'll put mine. I just wanted to comment on the duty of candour, Kim, and it's a question, but I think I know the answer. I know what you said about the numbers and absolutely for why they're there. In my recollection, very often what we were saying about our duty of candour was that the actual face-to-face conversation had taken place quickly, but the paperwork was perhaps taking a little longer, and that's why the figures were showing. So I'm asking, do you feel our colleagues are having time to get quickly where there is need for a conversation? And then I've got 2 more points.
Sometimes a patient's not well enough to have that conversation, so we're very much clinically led, and so sometimes there might be a delay in being able to have the actual conversation, and it's easy to do the written part, and sometimes it's vice versa. It also comes in 4 steps, so it's that logical part. So it's a mixture of both, but I'm really confident, and that's why you can see that already the upswing, that people are absolutely have duty of candour on their mind, and the clinicians work hard to be able to do that, and as the central governance team do everything they can with the governance lead to be able to support that as well.
Thank you, Kim. That's really helpful. And then, Jill, I just wanted to comment on the mortality and us being a bit out of step, and the delays on strokes and so on. And it is just a comment, but it is to say that one of the things that's difficult, I think, for us as an acute trust is that people don't see the effect of how busy we are. And it's kind of difficult to see that, but it's in figures like this, sadly, that we do sometimes see the knock-on effect. So while they are worrying and we need to keep working on them, I think as a board we need to note, we do talk about delays and how busy we are, but these are some of the effects that people perhaps aren't seeing. And I think as a board we need to just acknowledge that. We don't always see it. So that is not a criticism, that's a acknowledgement of the work we're doing. And thank you for your frankness on those. I've got Adam, Alison, Sarah, and I thought I had Richard, but he's disappeared for a minute. So I'll go with Adam first.
Thank you, Mari. Hopefully people can hear me. I was having a problem unmuting. A question on page 110 of our pack, which is on delayed discharges, which has been an area of focus and probing already in this conversation, in this meeting. So I'm not sure who the question's to, but could there be a summary of what conclusions should we draw in terms of trends and what's getting better and what's getting worse around delayed discharges and the information on 110, please. Did people hear my question?
We did hear your question. Thank you. Alison, you wanted to come in. I'll take you and then I'll pick up responses.
Actually, I'm just going to come in on about the people section. So I don't know whether you wanted to answer Adam first.
Thank you, Alison. In that case, can I take Sarah and then Richard and then wrap up all three questions, please? Sarah, then Richard.
Thank you very much. And of course, it's very concerning to see that we're such an outlier. And although it was somewhat assuring to hear the steps being taken on stroke, and that's obviously any improvement is to be welcomed. I mean, what more can we do? And I'm thinking, do we have a full complement of staff? Do we have a full service over the weekend? So is there more that we can do to increase capacity and flow and therefore the amount of people we can treat, particularly on stroke?
Thank you, Sarah. If I could take Richard and then ask Robin, you to gather up all three. Thank you. Richard.
Thank you, Mary. I've dropped my hand again, but it's because it's more of a comment. It was just really to what we did note at Finance and Performance Committee amongst our assurance requests on other areas was the use of the single operating framework that comes in this report today. And I just wanted to note that the Finance and Performance Committee will be using that as a key reference point for the recovery of the Trust alongside our monthly finance reporting so that we can align recovery against that single operating framework versus the financial recovery. So I just wanted to applaud the team for the way they pulled those metrics front and centre in the IPR, and they will be a primary focus for us in seeking assurance and scrutiny here on in.
Thank you, Richard. So, Robin, if you could field the question around the delayed discharge and the issue of what else we might do in terms of capacity around delays.
Of course, Chair. Thank you. Adam, are you referring to the length of stay chart, the stranded patients, or are you referring to the chart on pathway 0, 1, 2 and 3? Just so.
Thanks, Robin. It would be both charts, I guess, on page 110. I just want to be clear what conclusions should we draw in terms of trends, what's improving, what's deteriorating across both charts?
Thank you, Adam, that helps me. So in terms of the chart regarding pathway 0, 1, 2 and 3, the flow through programme has delivered the new standard operating procedure, SOP, for how we record patients on our electronic systems for data discharge and planned data discharge. We're now running broadly at any point in time when I snap audit the teams, 50 patients without an estimated data discharge. That's on a backdrop of 670 patients, so really good initial compliance there. We're also now, through our IT colleagues, have got a planned data discharge field. So what that's enabling us to do is to have an estimated date of discharge when the patient's admitted to the hospital, but then work to a planned date. And we're beginning to see that planned date compliance go up, and this is new, it's only been in place the last 2 weeks. We use that planned date of discharge to be really clear on how we get a patient discharged from the hospital, how we make sure that the actions are taken so there is no delay. And in fact, we are seeing some early shoots of recovery in that regard. So yesterday we achieved 61 discharges by 4 o'clock in the afternoon. That's a really high number for us. We want more, not happy with 61, but this is coming on the back of regular occurrences at 30 discharges by 4 o'clock. So we're starting to see that shift in terms of time of day. That builds through to the other part of answering your question, Adam, which is the length of stay. So the planned date of discharge helps us really target our actions along with estimated date of discharge, so no patient has unnecessary delay during their episode of care. So we can track down making sure patients have imaging on time, any other studies that need to happen, to give our decision makers the information as quickly as possible to make those decisions to discharge. On top of that, we've implemented daily wash-ups. So the next day we review all of our discharges, Could we have done better? And that's led through our Flow Out programme. And then finally, Alistair will be working with me on reinstating our long length of stay reviews, which is a supportive structure with our wards where we take our longest delayed patients and work through what further actions can we take either internally or with system colleagues to bring those wait times down. And you'll see on the graph we've got an initial, I'll call it an initial win, but it's so early days that I wouldn't want to say that that's a new trend, but I think that you're right, Adam, to highlight it. It's definitely something that we are tracking through our Flow programme. Hopefully that's answered your question.
Yeah, thank you for the further information, Robin. That's really helpful.
And then from a stroke perspective, there is more that we can do, and that's the sole reason why we have the stroke improvement group. There are works that we need to do in terms of how we make best use of our existing stroke nurses, how we make sure that they aren't pulled into our numbers when we've got staffing challenges. Kind of links back through to the update from John. Because we know if we've got our stroke nurses absolutely focused from a stroke perspective, we do achieve improved direct admission to the stroke unit. It does also link through to our need to have space on the stroke unit, and the drive with our partners for the instigation of the early supported discharge service, ESD as it's known, will then enable us to get more discharges from the stroke unit out back into the community, back home for their support at home, rehabilitation at home. Gives us space back in the stroke unit for those next readmissions to the stroke unit. We then know that once we get patients admitted to our stroke unit, the other measures that impact on stroke care around the swallow assessments, the intensive therapy, then starts to reduce length of stay and gives patients that improved outcome. And then you get on that cycle of improvement because you start reducing that length of stay. It gives us stroke beds back sooner for new admissions into the ED.
Thank you, Robin. Well done. It is assuring to hear you being so on top of it, be able to bounce our questions back. Thank you very much for that. Alison, you wanted to come in.
Yeah, it was just on the people metrics, just to highlight a couple of things to you. So regarding staff turnover and vacancies, whilst the turnover for most care groups is above 10%, I just wanted to congratulate general surgery and cancer at 8.6% and women and children that are at 8.3%. And some of that detail obviously isn't available in the overall stats. The other things I just wanted to bring to attention, again, though not where we would like it to be, but on terms of the staff, friends and family surveys, we have got an increase of 2% on those staff recommending the trust as a place to care, and actually a 5% increase on recommending the trust as a place of work, which I think is something again that we should celebrate. On appraisals, there is a very slight upturn in the graph. However, what I would say is fairly recently an appraisal workshop was conducted with a lot of staff from across the trust, and the output of that appraisal workshop will be going to the executive leadership team to consider next steps fairly shortly. Thank you.
Thank you, Alison, and that is to be celebrated. You know, the small changes still change, and it is in the right direction. And a bit like what you were saying, Robin, it's really nice to hear little kind of green shoots of things being a bit better, even though we don't underestimate what the challenge is. So thank you, everyone. Okay, I don't have further people wanting to speak on this item, so could I say that we have discussed for assurance and noted the month for integrated performance report, and then say my watch thinks it's 6 minutes past 12. I have had a request not to shorten the lunch break for various reasons, so could we take 30 minutes please and come back at 25 to 1? And then please, if we could all be responsible for trying to make sure we meet the 2 o'clock deadline. So thank you all very much, and we'll see you at 25 to 1. Good afternoon, everybody, and thank you very much for taking a prompt lunch break. I hope you have valued the fact that we've put a lunch break in rather than 10-minute coffee breaks. I've certainly felt that that was a good use of our time today. So we are coming on then to item 12, which is the month 4 financial position. And Carl, I'd be grateful, please, if you would introduce this report for us, and remembering that brevity means prizes.
Thank you, Chair. And the key points just to highlight to the board for me in terms of the month 4 is obviously the month 4 financial position is slightly better than plan, albeit please note obviously it's a deficit plan to date, and the plan profile aims to improve to the break-even position by year end over the next 8 months. There certainly remains a route to break even, and whilst that remains extremely challenging, some of the risks that we're aware of, that was the reminder to come back to the board meeting, Mary, sorry. Whilst there are a number of challenges in terms of the financial position, there are some also mitigations that we are pleased to be able to report in terms of additional funding, for example, on being able to increase our capacity to open the Tremenel upper floor again come November, and we are being directed to assume all the costs of the additional cost of the pay award will be funded, although the detail of that is yet to be advised. The outstanding issue around funding and or risk is around our elective services recovery funding. So whilst we've got mitigations in place in terms of what we're advised around any clawback of underperformance for the first 6 months, the second 6 months is yet to be advised. So clearly, in terms of our elective recovery programme, it's really important that we programme and progress with that in parallel with trying to improve our operational position overall. Steve touched on this earlier in terms of his brief, but in terms of our energy cost risk, we believe we've got mitigations through the contract arrangements with the Crown Commercial Service between now and the end of March. So the circa £2 million of cost increases that we built into our financial plan, we are not forecasting to see any material changes in that between now and the end of the financial year. Clearly the 23-24 financial year will be a complete change, and we're yet to understand what the impact of that will be, but certainly in terms of 22-23, I think our energy cost risk is covered despite the challenges internationally and of course in the UK. I think it would be inappropriate not to mention the savings programme. So whilst I'm highlighting a route to break even, including the shortfalls in savings, clearly this isn't a sustainable position, and improving our underlying and recurrent savings along with short-term savings to get us through this current financial year is a two-pronged programme that we have to take forward. And between Tom Lafferty, Director of Strategy, supported by Ella, and Ella's on the call with us today, we're going to take an immediate step around two elements of the programme. One, in terms of myself looking through all the current budgets and aligning that with our forecast outturn and seeing where short-term savings can be delivered, and Ella and her team looking at the more transformational and longer-term savings, which Mary, you might wish Ella to touch on in this session as well. So very much challenges in place. The forecast outturn to deliver break even, there is still very much a route through to delivering that, and any major variances I'll of course report through Finance Committee and into the board. Just very quickly on capital, if I may. So pleased to report that the initial planning gap that we set as part of the initial capital programme, we broadly mitigated that with a number of measures, as you'll have read in the report. I think at this point in time, the biggest outstanding issue relates to £1.3 million worth of funding that we are still expecting in relation to the West Cornwall Hospital's business case. And whilst we still have not received feedback from the centre on the status of both the funding and the outline business case, that £1.3 million in fees remains an outstanding issue, and that's certainly a focus for me, having the discussion with the regulators. Again, the last discussion was 2 to 3 weeks ago, but again in the next couple of weeks. And just a final point in terms of cash balances, and the month end was just under £20 million with no issues to raise with the board. So, Mary, those are the key issues I want to bring to the board's attention in terms of the financial position.
Thank you very much, Carl, and well done for brevity. Richard, is there anything that you would like to add to Carl's remarks about the paper?
Not a great deal. I won't spoil Carl's brevity by talking too much. I think the only thing, well, everything that Carl said is where we're focusing. What I mentioned earlier, I think is important that as Finance and Performance Committee, we're looking to strongly align our recovery profile in the IPR with our finances, and particularly thinking of the Electric Services Recovery Fund and the impact that would have if we were failing to recover. But of course, our primary focus is ensuring that the citizens of Cornwall get the best treatment and the best recovery. I think the only other area, and if Ella is going to comment, we do note that SIP, the Cost Improvement Programme, is lagging behind where our projected targets are, and there's a degree of centrally held SIP to which we don't really have very clear visibility as yet as to where that is going to be levied and leveraged against. And so we've asked for a piece of work for next month's committee to get a deeper dive into the central held cost improvement programme savings.
Thanks very much, Richard. Ella.
Thanks, Murray. Yeah, to add to that and what colleagues have already said regarding the SIP programme, there are some actions RCHT focused we're taking immediately, having had discussions with our care group managers around what would enable them to deliver more at pace on this. There were some themes from those discussions around procurement, as we know, which is really challenged this year with the inflation. So where they may have looked before for procurement savings, they're finding that quite difficult on price. So we're looking to do something different this year, which is re-establish a non-pay board, which rather than looking at prices of specific products, we'll be trying to look at themes across the trust around perhaps there's efficiency through how we use products, non-pay elements, and how we can be more efficient reducing waste across the board. Procurement colleagues will be key there, and they've already got some ideas around where we might look. The second theme was around medicines management. So again, there have been for a while forums driven by our pharmacy colleagues around looking at efficiency in how we use our medicines. However, we're going to support that from a QI perspective to ensure that there's real follow through on the actions and any cross-trust themes are picked up and worked through, bottomed out. The third one was pathology services. So there was a feeling that, again, in the way that we make use of pathology services, there could be some opportunity for efficiency. So this is, for example, the types of tests we order, how frequently we do those, making sure that we're kind of in line with best practice, really focusing on from a quality angle, but also with an efficiency lens. So there are three things we're going to get up and running this month internally with care groups. There's also a big piece of work gone on across the system with support from KPMG, looking at benchmarking opportunities. So how we as a system, and specifically some of those relate to RCHT, how we compare to other organisations, where there may be opportunities for us to be more efficient. So my team, having very kindly been freed up from some of the more, should we say, like performance management and monitoring by Carl's team of SIP, will have more capacity to do the change management with teams. And then the final thing I would say is really the more medium-term view along the work we're doing with our provider collaborative and the shared services review that we're also getting underway, because I think we've all acknowledged for a long time now the true transformational work will sit in working with our partners. So yeah, I hope that provides some assurance that we are taking those things forward.
Thank you. That is assuring. Carl, you picked up my two questions on this report, and certainly that assurance around the SIP is very helpful. Listening to what you're saying, Ella, that you're really talking again about culture change, aren't you? About the way we do what we do, and being mindful of how small things add up to being a big thing. I was actually thinking, Robin, I really liked the little pop-up that came up the other day about getting people up and out of bed and dressed, and I wonder if we could do some pop-ups around that as well. Do you need this, or could you do with less? So I think that it is that culture piece, isn't it? Yeah, that's great, thank you. Could I pick up, while colleagues are thinking of any further questions of their own, you touched on the West Cornwall, Carl. I was just wondering whether, I know you've said you've spoken in the last 2 or 3 weeks, but is there any timing around this as to when we're here? Because, this is a small hospital that's very much part of its local community, that hanging on, waiting to hear, aren't we?
This is incredibly important. We've got we had a good business case which is ready to go, and we are in the lap of the gods in terms of when it goes through any kind of process. The last update, which was literally last night, in terms of how capital nationally is being looked at, is that it is being reassessed nationally and or then regionally in terms of schemes. Because you'll have probably read in the press, I don't think there's any secret in this, that in terms of funding the national pay awards, the national team and regional teams are looking at all sources of funding to bridge any financial gap. And as I said earlier, we've been directed to assume all funding for the pay awards will come through. So we do not know what the impact of that will be on any of our capital schemes, or if there will be any ask in terms of slippage or further. So it is literally, despite asking the question, silent. But I can imagine the position will change over the next probably 3 to 4 weeks. And that's directly from the Secretary of State's office. We understand that review is taking place.
Thank you, Carl. And can I just check? I'm sure that we are keeping the communication going well with West Cornwall about this. Is that who's leading that comms with West Cornwall?
If I could briefly comment, if that's okay.
Please.
Tom Lafferty is our lead for engagement with the 3 integrated care areas, including the West Cornwall integrated care area. So he's been using that mechanism and that route to keep colleagues in West Cornwall updated on that progress. And of course, all of the executive directors who are directly involved use their own networks. But in terms of engagement, particularly through the health and integrated care partners in West Cornwall, that would be under Tom's auspices in that role.
Thanks very much, Steve. That's helpful. Colleagues, are there questions on this report? So, Isabel.
Thank you, Mary. And thank you, Carl, for a really helpful report. The question is not directly linked to the report, but it's a question more around contingency. And I wondered whether any discussions have taken place or are planned to think about any financial implications of any initiatives that we might want to consider to support our staff with the cost of living crisis.
I certainly agree. We all, the exec, are very supportive of looking at all options we can to support our staff, and Alison's implemented a short working group to try and look at those options, and in parallel with the CFT, because I think that's really important. I think in terms of the value and size of what that might look like, we haven't got a feel or view on that at the moment. So how that may or may not impact on the financial position, we'd obviously have to bring that back. But certainly in terms of support in principle to see what we can do at these really difficult times, we are right behind looking at all those options.
Thank you.
Alison, would you like to comment at all on that, please?
Yes, just as Carl indicated, at the last executive leadership team meeting, a small working group was put together. We are looking at a range of options regarding food, transport, ways that staff come to work, the package that they received whilst in work. It's a little bit too soon to give the details, obviously, because we'd need to work them through the normal governance structures, but hope to bring it back to board very soon.
Thank you very much, Alison. That's really helpful. If there aren't further questions, Carl, could I just come back on the SIP performance? I mean, we've heard what we're doing to mitigate and improve that. That will, I assume, be continuously monitored by Finance Performance Committee, because my concern is we're behind already and we're in month 4. I don't want us to go on falling behind.
No, forgive me. I hopefully didn't imply anything other than detailed monthly updates, and certainly we're doing when we go to the month 5 committee, there'll be more detail around where we are in the forecast. At the moment, the mitigations around the underperformance on savings essentially is our underlying run rate, which is below establishment and below the pay budgets. So it's almost looking at the current month's positions around £900,000 a month, our sort of underlying pay underspend. So that's offsetting to some extent, or to a greater extent actually, the SIP under delivery. We're projecting that to continue for at least 3 to 4 months, hence why we're still projecting a forecast that is and a route through to break even to the year end. And as I mentioned, that's not sustainable. We have to really get into detailed plans around cost reduction in the right way, efficiency improvement, productivity improvement. And that's why we're going to do this two-pronged attack to look at what can we do here and now to make sure we're going to deliver the in-year or improve the in-year delivery, yet look at the underlying financial position and recurrent improvement going into 23-24.
Thank you very much. Other comments? So thank you for what Finance Performance Committee is doing on working with you, Carl, and to you, Ella, and your team for the work going forward on this. We're asked to note the 22-23 financial position for 4 months up until 31st of July across revenue and capital budgets, and note the current risks which are outlined in the paper. If you'd be good enough to note that in the chat, please. Bringing us to item 13, which is the committee assurance reports. I'm going to take assurance from each committee in turn, and I will invite the chairs to make any very brief comments they wish to make, highlighting assurance that you've found or risk that we should noting. I am guided by some of the governance reviewing that we have been doing. I am thinking that it will be helpful for the board if in future we both position the committee assurance reports earlier in the agenda so that we can be fully cited on the considerations of committees before receiving our main items, so that we can join up the work that's done on the committees and the main items. And also I will be asking committee chairs if they would briefly let us know the assurance that they have found. So together with your report, if you're able to add some verbal. This is something that we used to do, and although we were trying to manage the time on that, we need to be careful with it. I think board did find it helpful that people were introducing those reports. So having started with that, and Sarah, I am now able to take the Charitable Funds Committee first. Have you any further comment on this report?
I think the report covers all the areas that we discussed because of the ongoing financial situation. The committee, I think, has taken great care to protect our charitable funds, and I particularly like to thank the work of my colleague Nina, who's been very persistent in ensuring that we do really protect our charitable funds in a range of bank accounts. But to note that with the ongoing financial uncertainty and the prospect of a recession, clearly our returns on investments aren't what they were. That's in common with everyone else, and while we keep it under careful review, this will have impact on the amount of money that the charitable funds will able to allocate towards supporting our patients and our staff.
Thank you, Sarah, and thank you, Nina, for that tenacity. Are there questions at all for Sarah? Yes, Adam.
Thank you, Mari and Sarah. It's probably a question for Carl, actually. So very supportive of the recommendation, and Sarah mentioned about the spreading of risk through establishing 3 further bank accounts. It's just being assured, please, that we have some kind of process in place for checking on an ongoing basis the financial robustness of the banks that we are going to invest with, is the first question. And the second question is, are we setting ourselves an upper limit on how much we're prepared to invest in one individual institution?
Yes. Sorry.
Yeah, go ahead.
Yes to both, Adam. So I can't quite recall the numbers off the top of my head, but yeah, so we will have investment thresholds set as part of the limits for investment, and of course the type of investment we can enter into. In terms of the banks, what we would normally do is obviously just go with sort of big institutions. So it's highly unlikely that we would enter into any arrangement with organisations that are set to fail. But of course, who knows in this day and age. So what I will take back to the team, just to make sure we build in a regular review of assessment through the we use Dun & Bradstreet tools to make sure we can test a lot of the contractors that we enter into arrangements with. So we will do that on a regular basis and report back, Adam, into committee.
That's great. Thank you.
Thanks very much, Carl. Other questions? Which case we're asked on 13.1 to note the items considered by the committee and to approve the establishment of 3 further, to make 4 in total, instant access bank accounts for our charity, and to delegate authority to the charity treasurer or nominated individual to enter into those arrangements. If you could indicate your approval, please. Then 13.2, our Audit and Risk Committee. Sarah, any comments you'd like to add to your report?
I think the report speaks for itself. I'm always very appreciative of my colleagues' time and effort in reading the reports and entering into such thorough discussions in the committee. We are embarking upon some work with our systems partners. It was great to hear John and Kate this morning talking about working as partners and not duplicating effort. One of the areas I think there is a risk of duplication is in the governance arrangements of each of the different NHS bodies in Cornwall, which I'm very keen to do everything that I can to prevent that duplication of effort and waste of time and money and resource. So I have called a meeting with the audit and risk chairs of ICB and our partners in the system, so including CFT. And I think we're about to, with Lindsay's help, get a date in the diary so we can work out how we can work together really well, which I think will improve governance, improve scrutiny, but save a lot of time, money and effort. So I'll regularly update us on the progress that we're doing on our systems auditing work.
Thank you very much, Sarah. Are there questions for Sarah? And really good to hear about the liaison across the system. So, colleagues, if we could note the items considered by that committee on the 14th of July, and come to 13.3, the Finance and Performance Committee. Richard, any further comments you'd like to make?
Just ask the board to note some of the risks in the report. The report's very full. Probably worth highlighting that we did, on behalf of the board, sign out the outline business case for the Women and Children's Hospital, so that is progressing through now. I think we've covered some of the other items of note in the agenda. We also managed to, as is in the report, authorise further payment into the tower block, or recommend to the board, sorry, for authorisation of further payment into the tower block fire risk mitigation. And I guess I'd just like to draw your attention also to the 2 appended papers, the premises assurance model, which is here for the board to recommendation to endorse, and the 6-facet survey that we've been waiting for a little while, and that's here for noting. Nothing else to give by way of introduction.
Thank you, Richard. Colleagues, are there questions for Richard about the work of this committee? Again, a very big committee doing a lot of work on behalf of the board. If I could take 13.3 first and then come to the appendices. So on 13.3, we're asked to note the items considered, note the risks identified in regards to the material risk to the strategic capital programme, backlog maintenance and clinical transformation as a result of the clinical continued delays to the progression of the Women's and Children's outline business case. We do note, as you've just said, Richard, that the committee with its delegated authority has agreed to submit an outlined business case to the new hospital programme team and further to the conclusion of the cost review. We're asked to note further the confirmation received of the enabling works fees allocated to the Trust in 22-23 to progress the Women's and Children's Build scheme. We're asked to note also, as we've just been discussing, the delivery against the SIP, which is a high-risk plan, and that is currently being managed in the ways that we've heard in the previous item. Also, note the urgent need to clarify the executive leadership arrangements for the totality of the Trust Estates and Facilities Service, recognising that the current arrangements were only designed to cover the short term in the face of both increased risk and opportunity within these services. So if you could just note those matters. And then coming to, as you mentioned, Richard, 13.3.1, Robin, is there anything you'd like to add at all to the premises assurance model before we take the paper?
No, thank you, Chair.
Thanks very much, in which case we're asked to note the report and endorse the premises assurance model, agreeing to the self-assessment question ratings to be recorded on the national reporting system through NHS Digital, and also noting the premises assurance model is dynamic and likely to attract further change, which we have seen in paragraph 1.7 prior to the final submission. We're then asked to endorse the proposed governance structure for providing assurance on the premises assurance model to the Finance and Performance Committee. So if we could please do that. And then come to 13.3.2, which is a starred item, and I haven't been notified of any comments or questions. So we are asked to note the report and its associated recommendations. Thank you very much to that committee. Then come to item 13.4. Could I invite Ruth Allerton to comment on the assurance report from the Quality and Assurance Committee?
Thank you, Mary. You have in the report summaries of the 2 Quality Assurance Committee meetings held since our last board, and the joint Quality Committee that we hold with our Partner Trust CFT, and there are no additional risks to raise to the board. I would like to thank colleagues on working on the agenda with me to ensure that we're fully sighted on the key risks and worries that we have in the Trust. I think of note, we received the organ donation annual report last meeting, and we just wanted to particularly acknowledge the work of all the staff involved who support patients and relatives throughout that organ donation process. Thank you.
Are there questions for Ruth as chair of that committee? No, I'm glad you noted the organ donation report. It is a starred item and I haven't been notified of questions, but I probably just do want to, as you have, Ruth, celebrate the work done by those teams, but also just remark on the fact that over 50% of the Cornwall population is signed up to be organ donors, and that is one of the highest, if not the highest, in the country, which is quite stunning, and gives us a burden to try to manage the numbers as time goes through. But it's greatly to the credit of the people who do that work that we're there. Thank you for that. So on that item, we are asked to note the Quality Assurance Committee report, and then the starred items of 13.4.1 and 13.4.2. If we could note those, please, in the chat. Bringing us to the People and Organisation Development Committee. Adam, is there anything you would like to comment on your report?
Thank you, Mari. I mean, the report is very thorough, covers all the issues we discussed. I suppose I would like to highlight, and we all know we're operating in challenging times, and just to reaffirm that thanks to everybody working in the Trust for all their hard work. Particular thanks to the personnel team, who are often hidden heroes, beavering away, supporting the organisation. And it's been mentioned already, the NHS Pay Award. Particular thanks to the payroll team, who are working hard to implement the new pay award, which is not a straightforward process, but they're working hard to deliver that. So thanks to everybody working hard. The report stands on its own, I think. Thank you.
It does. It's a very thorough report, and as were the committee papers. Questions at all for Adam? Yes, Ruth.
Mari, less of a question, more of a comment. John quite rightly challenged us about recruitment processes and how quickly we get people into the trust. And I think it's worth noting that we did discuss that at our People and Organisational Development Committee this time. So we are cited on it, and our teams are working really hard to do something about it.
Thank you, Ruth. And did that include the points that John was making about the trend towards people wanting to work not full-time?
Not specifically, but flexible working is a key point that the Trust recognises and works towards.
Thanks, Ruth. Isabel.
Just to build on what Ruth's just said, I think that what's been agreed is that those metrics are going to come to the future performance committees to look at the lead time measurement from initial advert to actually start date when we've recruited. So I believe that's already been put into motion. So we will have that information.
Much appreciate that. In which case we're asked to note the items considered by that committee in its August meeting. 13.6, the Remuneration and Appointments Committee has meetings in July and August reported in this item. Ruth, do you want to add anything at all to that?
I don't think so, Mari. The report is as it stands. There's a lot of work going on currently in the committee, and Steve already reported about the dual posts in his report. So I think the report is as stands, really.
That's great, thank you. And those dual posts are to be celebrated. Really, it's a milestone, I think, for both trusts to be going down that road. So that's great. In which case, could we please note 13.6, the meetings held in July and August. Bringing us to item 14, the Annual Equality, Diversity and Inclusion Report. This report was scrutinised by People and Organisation Development Committee. May I ask you to comment, Adam, in a minute. And this annual report and embedded action plans is an important statutory requirement for us to be receiving and commenting on. So, Alison, if you could be good enough to introduce the report, please. It is a long report, so succinct plus a 10-second will be fine.
Okay, thank you. As you said, Mari, this is a long report. It's a consolidated equality report for all the reportable areas of the protected characteristics such as race, gender and disability. As you've already said, it's gone to pod. Further amendments have been made. And what I think is really important now is that the pod committee continues to monitor the action plan as detailed in the report. I'm seeking formal approval of this action plan today. In doing so, I'd like to recognise on Action 6 that Health Inequalities is led by Alistair in his role as Chief Medical Officer, and Action 9 will be led jointly by Kim as dual Chief Nurse and myself. The other key highlights, which I will quickly go through, is just to focus on some of the points that came out of this report. So, for example, looking at our population of patients, over 10% of our patients had a disability. 0.2% of patients were transgender people. Following changes to terminology regarding race and ethnicity, the new preferred terminologies are now white British or ethnic minority, and therefore we have 82% of our patients being white British and 5% being ethnic minority. In terms of patient population, we have a 50% split between male and female, and if we compare that then to our workforce, if we look at our bank staff as recorded as of the end of March this year, where we had 9,400 staff, we've got a good representation between ages and gender. There is lower representation for under 25s due to still being in education in part, and what you referred to a few minutes ago in terms of an increase in staff wishing to work more flexibly is very much evident in staff that are over 55. When you look at promotions tend to happen in two spurts between the ages of 21 and 35, and a second flurry seems to happen between the ages of 46 to 55. Therefore, we do really need to spread out promotions much more. 4% of staff, as I say, declare a disability, and we have got a good range of staff with different religions. However, the majority is Christian at 39%, and then Buddhism and Islam being next highest, with a small proportion of 0.5%. And I expect that religion demographics to change over the next coming year as we recruit more international staff. Turning to the areas where we do need to focus on, when you look at the nursing staff included, then we have 75% of our staff being female and 25% being male, and that male input then leads to driving pay inequalities on gender, and predominantly what sits behind that is 65% of our consultants are men. Now, just looking at some comparators, if we were to look at UHP, although their statistics are not up to date because they're probably in the process of presenting their report to their board at the moment, their pay inequality and pay gender gap was 15%, and ours has nearly doubled. If I look at another trust, for example, St George's, that also holds true. So therefore we have a lot of work to do on addressing the gender pay gap for women. Just as a general point as well, staff with protected characteristics are more likely to find themselves, or the data has shown, in a formal disciplinary procedure. However, I would like to end in a really positive point, because yesterday I met with an international nurse and she'd found herself in a difficult situation and told me that she felt completely supported by her line management. And I believe that the work that we've been doing over the last year on just culture is starting to embed. So I would expect things to improve as we go forward in that respect. However, as you can see, big report, lots of work, lots of actions for the organisation as a whole, as well as POD. Thank you.
And I really value this report. There is a lot in it, and there's a lot which we need to be paying attention to, as you've indicated. I do have a couple of points I'd like to raise, but Adam, as Chair of People and Organisation Development, would you like to comment?
Just briefly, I'm conscious of the pressures of time. I think Alison's summarised it very well, but obviously the report highlights lots of significant issues that we need to address. So to emphasise to the board the importance of the action plan on pages 309 to 311 and making sure that we do our best to deliver that action plan, which is obviously what Pod will keep an overview of.
Yes, thank you. I would really like us to stay on top of this. Some of us who have been involved in this reciprocal mentoring programme have heard still some quite distressing stories of how we're not quite getting it right yet. So I think keeping on top of this is very important. Are there other questions on this report? No? So I do have a couple of comments, I really did welcome seeing the work being done with the events calendar and the trying to respond to differential religious beliefs, as Alison has just said. I think we need to do more of that. I think these statistics show us that we have got the opportunity to do quite a lot more, and in welcoming international nurses in particular, but not just those. How nice it is to have a workplace where we can recognise different religious holidays seems really important to me. I think it's vital that we get our responses to the adjustments and the differences that we make for our different religious communities absolutely spot on right, and we take opportunity to do that. I have noted the pay gap issues, and it's pleasing to hear what you say, Alison. And I was very informed by being told what is the correct language for us now to be using. So that was really valuable. I think there are places in that report, which I know is a really long one, where I think there are a few typographical errors, and I'm just wondering if you would forgive me whether there might be time for us to just adjust some of those before it does stand as our annual report. They're not great, but I think they're important. So I would request that, and I'll come to a recommendation for that at the end of this debate. So those would be my comments. Richard, you're muted, Richard.
Sorry. No, okay, thank you. No, just two quick comments or questions, really. One is around the health inequalities in the action plan, etc. Can we align this with other data that we have? Because I appreciate the nature of the report is to look at specific areas of characteristics, but things like socioeconomic, things like geographic impacts on health inequalities, so how we make sure we address things in the round rather than silo them by the areas we've looked at. And then secondly, perhaps just a general comment on how we're going to use the data on particularly our staff to help address, or are there any directional arrows pointed here to help us address our vacancy rates and our recruitment in terms of addressing some of the balance, and how we're doing that proactively rather than by serendipity?
Thank you, Richard. Alison, are you able to pick that point up?
Yes. So I think the first point to say is I think Alistair's already scoped a paper. Forgive me, I can't remember where that paper has gone, bringing those points together around health inequalities. I think the point that you raised, Richard, more broadly around intersectionality is really important, that we don't just look at the data in component parts, because most people will have several protected characteristics that they are in as a person. I believe, although I wasn't at the pod committee due to holiday, I believe the pod committee had a really good conversation around what they can do to drive change, in particular around the gender pay gap. For example, about making sure that our recruitment panels were much more balanced and representative of our workforce. But to say there is a whole set of actions as well in terms of us increasing our sophistication through data and the work that we want to do with the HR systems as well as more broader general education and our staff being aware that we've got a problem and the problem that we want to fix. So there's a sort of a general communication point as well. Thank you.
Yeah, thank you. Welcome the report, Alison. It's a critically important one to us, and I'd like to say thank you for the huge amount of work that's gone on in the background. Our staff networks are referred to quite rightly several times in the report and in the action plan. I think the opportunity for our individual staff networks to assist in supporting this, but also the point you made about colleagues who have experience across a number of protected characteristics, the opportunity for the networks to work together, I think is really powerful as well. I think everyone who's commented has spoken about the importance of addressing the gender pay gap, and I'm very glad that you drew that out so explicitly. And it might be useful for us, Mary, as a board, to have updates during the year on the steps that we're able to take to address that and the other steps that are being taken. And I'm mindful here, Alison, that we're such a large organisation, we're an anchor institution in Cornwall and the Isles of Scilly, that the impact of the steps we take can have a significant impact across the broader community as well. And I think that just reinforces the importance to me of progressing these areas.
Thank you very much, Steve. I think that would be helpful. It would go through People and Organisation Development Committee, but then come through to the board, which would be really useful. If no other reason, that we know health inequalities are significant and lead to ill health, and we're entering a really worrying economic climate, aren't we? So I think that makes a lot of sense. Carl.
Thank you, Chair. You touched on this a little bit, Alison, but in terms of the age data on page 268, and just looking at some of the numbers, which I don't know how we benchmark in terms of the age profile, 56 to 70, but looking at this, 18% of our workforce are currently age 56 and above, and that linked into the current gaps we've got on our workforce, and indeed perhaps some of the successes of bringing people back through the really difficult COVID period. I think any kind of retention strategy and or opportunities we've got to think about how people can stay with us during that period, because clearly NHS pensions, people think about retirement 55 and above, depending on what class of staff you are, but those numbers look highly concerning in terms of our workforce going forward. And when you look at the banding as well, I'm proxying this, but looking at numbers of band 5s, take as a proxy of nursing staff, there's 200 and nearly 300 in that sort of banding, and I can't say how many explicitly, but those are some concerning numbers in terms of our age profile and a consideration for us going forward.
Thank you,
Would you like me to respond, Mary?
Yes, please, Alice.
Yeah, I think the points that you've drawn out there, Carl, also sort of refer back to some of the points that Kate made in her presentation too. And for me, it isn't just about, growing the workforce. I think we've got to think a lot more creatively around career opportunities for staff. To go sideways, and actually, we offer so many careers, but perhaps some of our staff retire and don't know that those opportunities are there to be taken. So we've got to do a lot more supporting our staff. Yes, we did well in bringing staff back during COVID, but I think the trend is now for staff to retire. And we're not retaining as many, particularly, Kim might want to come in on this point, nurses, they're tending to go. and some of it obviously is reflective of the pressure that they've been working under. So again, I think it harps back to us being a lot more creative with career opportunities and allowing people to move sideways, downwards, etc.
Thank you, Alison. I'll bring Kim in, but that brief discussion just gives rise to a different thought, which is it's not just NHS people who are retiring that we might bring back in to employment. There's a lot of other people retired in Cornwall and the Isles of Scilly who may have a great deal to offer. So I think that speaks to that recruitment piece, doesn't it? Kim?
Covered a little bit of what I was going to say. I think, no, that's all right. It's like ward clerks, isn't it? Administration, cleaners, everyone is making lifestyle choices, especially as they come to retirement. I think for the non-medical workforce, and it probably won't be different for the medical workforce, I hate the term, but it's called legacy. I probably fit in that age category, but it is about how when our staff now are, that even those that said they weren't going to retire at 55 now plan to. How do we keep their skills in? So we hear a lot about portfolio careers, and that's exactly what Alison was saying. You know, if you want to do a day in ED and a day on one of the elder care wards, or you want to do outpatients, how do we start to think differently? And we've got enough vacancies if you want to do clinical supervision and help wards. We've got to think differently and make sure that we bring them back in. They're very clear. They don't want to do shop floor work anymore, whether it be 6 hours, 8 hours, 12 hours, but there are so many things people can do differently. And then it's the advanced practice. How does that help our non-medical, our medical workforce, as well as give some of that support back to junior doctors as well with their skills and knowledge, acknowledging that the last 3 years our students coming out are feeling scared. They haven't had the skills and the opportunities during COVID to practice some of their craft.
Absolutely, Kim. I could go on for hours about what the opportunities might be, because they're really exciting, aren't they? And, you know, mandatory training delivery and all of that sort of thing. And just while we're on the subject, I do think our society gets our language wrong. And I think the word retire is really a weird word. I've never liked it ever since I was very young. And what does it exactly mean? You know, retire from life or something? I don't know. But I think we need to. You know, social constructivism suggests we should describe things differently, and it's what next as opposed to retire. But anyway, sorry, I get passionate about things like that. Are there other comments for this report? Alison and Adam, I hope you feel that there has been a real good amount of interest generated. It does matter very much to us as an anchor institution, but also as a general employer. I referred earlier to there being some typographical errors, one or two of which I think are material, but also some little things like page numbering and things. I might have got a different version, but I wonder if it would be possible for me to suggest a recommendation to the board that we do just take away some of those minor and other corrections and delegate to Adam as chair of the People and OD Committee and Alison just to oversee those small corrections, and then we can submit in a timely way. I think we would have to have that piece of work done by the 23rd of September in order to submit, although I'll defer to Sian in that timescale. But I think if that would work, and there are no further comments, we are asked to discuss and note the information presented and the current programme of equality and inclusion activity, including the successes and opportunities. And I'm suggesting that we do approve the report to be published in line with the Equalities 2010 public sector duty requirements. Pending my recommendation, we delegate authority to Adam and Alison just to make those typographical corrections. If that would be acceptable to board, then perhaps we could indicate in the chat. I will send you my notes, and if anybody else has any notes they'd like to have considered, please throw them in. Then we come to item 15, the summary consideration of risk. I'm going to invite Sian as our Company Secretary to reflect any additional risks to those already on the board assurance framework or the corporate risk register that have come up during today's meeting. Sian.
Thank you, Chair. I didn't pick up any new or emerging strategic risks for the board assurance framework, but in the context of the discussion earlier about risk sharing across the system, there is a risk on the BAF about a risk of a lack of alignment on strategic priorities between the organisation and the system, and that we may wish to, if the board wish to, we may wish to just tweak that in light of the discussion on risk sharing. We noted the risks highlighted by the Finance and Performance Committee, so just to go through those, to close those off. Delivery of financial savings risk is already within the corporate risk register. Capital funding risk is an existing strategic risk on the board assurance framework, but there is potentially a new corporate risk on leadership arrangements for strategic and operational estates, which is being taken forward by the Chief Executive at the moment via Remuneration and Appointments Committee. And then I'll just invite executive colleagues if there's anything I've missed where they are lead risk owners for the BAF or corporate risks. Thank you.
Thank you, Sian. That was really helpful and in line with what I think I'd picked up. Are other directors aware of anything, or anybody aware of anything further to add? No. So if we could please do that piece of work, Sian, that you've outlined for us, and then come to the questions from members of the public, whom I thank greatly for your patience in being with us during this meeting. There is a role for the people who are also attending the meeting as opposed to those who are at the meeting, because we couldn't do it without you. I'm grateful for you being here. I'm going to invite Sian, our Company Secretary, to read questions posed from members of the public, and those have been looked at in line with the protocol, which you do have in your agenda pack. Sian will ask those, and I, myself or Steve, will field them to the appropriate executive director. We do only have 15 minutes for this item, so I'd be appreciative of people being succinct where you can. I think that's my word of the meeting, isn't it? But there we go. Sian.
Thank you, Chair. We've got 8 questions from members of the public. The first one is from Daisy White to Kim as our Chief Nursing Officer. Daisy asks, which board papers specifically referred to the decision to refuse to allow unvaccinated people to have work placements, since it's not statute, English law, nor does it appear to be a specific policy of the Trust. I applied for midwifery work experience and my application was turned down because I've not been COVID vaccinated. Thank you, Kim.
Daisy, I will, if Sian can please send you my email address. You might have applied during the peak of COVID, and we were trying to prevent the most vulnerable, and especially our own patients, from becoming infected. But we've moved on, and we've got personalised risk assessments. So if you can just get hold of me, we can progress through.
Thank you very much, Kim, and I hope you will do that, Daisy. Sian.
Thank you. Question 2 from Anonymous to Robin as Acting Chief Operating Officer. Are there any plans to improve the 24-hour service at West Cornwall Hospital, and as it's been closing in the evenings very frequently recently? Thank you.
Thank you. Yes, West Cornwall Hospital has been shutting recently due to staffing gaps. Our team are working tirelessly to close those gaps, because we do want West Cornwall Hospital to be open 24 hours a day, but it's staffing shortages that's causing the challenge right now. Thank you.
And we have to be able to run a safe hospital. That's
right. There's minimum staffing numbers we must achieve to be able to open the unit.
Great. Thank you, Robin. Sian.
Thank you, Chair. A question from Jane Bernal. Which services now use patient passports or other patient-held medical records? Are they available for community and primary care services to give to relevant patients? Are those services aware that such passports intended to facilitate patient-centred communication exist? And that's to Kim as our Chief Nursing Officer to start off. Thank you.
Thank you, Jane. So 3 strong ones come to mind. It's the Learning Disabilities Passport. We've also got This Is Me for our patients with dementia and cognitive impairment. And we've also got our Carers Passport, where carers can enter into how much participation in their care of their loved ones they wish to give while maybe being an inpatient or using one of the system services. I think those are the 3 big ones that come to mind, and yes, they're available and used across the system. We are growing those passports, so that list keeps growing. The most grounded electronic passports are the maternity handheld electronic notes, but I don't know if Kelvin would like to come in about any future of electronic patient records there.
Thanks, Kim. Yeah, completely agree that the maternity electronic record is the most mature solution that we've got. We're also introducing new capabilities such as the patient hub. So patients who come into RCHT are invited to join the patient hub, and increasingly that's sharing information with them. And the new Devon and Cornwall Care Record. In the future, we'd expect to start to make information available for patients through that as well, but that's something for the future.
Thanks, Kelvin. John.
Thank you. Question 4. This is to Robin as Acting Chief Operating Officer from Jane Bernal. Jane asks, what routine communication is there between ward staff, the patient's relatives and a GP during an admission to facilitate continuity of care, allow early, smooth discharge and prevent readmission? Thank you.
Thank you, Jane. So the first thing that happens when a patient's admitted to a hospital is an electronic message goes out to the GP, so the GP knows that they're with us. In terms of engaging with patients and their relatives, we encourage all of our ward teams to liaise with patients to answer, for the patients to be aware of and answer 4 questions. Why is the patient in hospital today? What is the plan for the patient today? What are we doing to progress their care? What needs to happen for the patient to be discharged? How well we need the patient to be for them to be able to be discharged? And then finally, we encourage the final question to be, what is the planned date of discharge for that patient, so that the patient and their relatives are completely part of our discharge planning process and the overall care during their stay with us. Thank you.
Thank you, Robin. John.
Thank you, Chair. Question 5 from Jane Kirkham to the Chief Executive. Jane asks, she says, Sarah Newton was talking about the social care workforce that was within the Integrated Care Board item earlier. The Council have tried to raise the salary to £10.50 an hour. Pay is a massive part of the problem. It's less than the NHS. I know some money has been switched about, but in lieu of the government deciding to properly fund social care, is there anything the ICS can do as a system to put further resources into the social care element so that pay can be re-looked at? Thank you.
Thank you, Sean. Thank you, Jane, for the question. I think that partly refers to the comments made earlier on, and just to recap briefly, CQC, the Care Quality Commission, in their external independent expert function in the inspection of our system at the end of March, identified that adult social care in Cornwall had some of the highest staff vacancy rates in England. They described that as a staffing crisis and provided some observation on the impact that had directly on emergency department delays and on ambulance response times. Significant investment has been allocated from the NHS to our local authority partner, Cornwall Council. That's through a number of mechanisms. Firstly, through the Better Care Fund, and the Better Care Fund is one of the mechanisms to enable support to be provided to assist in discharge. In addition to that, though, a very significant financial allocation was made from what was then the CCG, that's now become the Integrated Care Board. £33 million of funding was transferred from the NHS to Cornwall Council under a S256 transfer, and that's the second significant financial allocation which has already been made. I have suggested to the Integrated Care Board Chief Executive that it would be helpful to the system to have reporting back against that £33 million, so colleagues and partner organisations can see the impact of the schemes that are enabled by that transfer of funding. And finally, it's also the case that operationally the Nursing Agency Bank, which is operated by RCHT and the community partner CFT, has enabled a significant number of nursing and other bank support shifts to be provided into care homes across Cornwall and the Isles of Scilly. So in addition to the financial allocations already made through BCF mechanisms and through S256 transfer mechanisms, there's also that operational support as well.
Thank you very much, Steve. Sian.
Thank you, Chair. Question 6 is from Peter Levin. This is to Kim as our Chief Nursing Officer. Peter states, the Trust recently reported that there are now over 100 RCHT acute beds occupied by patients who are waiting for social care or other community support before they can be discharged. What does the Trust do to provide care for these people? Almost certainly they themselves don't want to be there. Do you know how being told you don't need to be here makes them feel, especially as they will know that clinicians' and nurses' attention is focused on the patients whom they are in the middle of treating? Thank you, Kim.
Thank you. Peter, I would sincerely hope that none of our staff would ever say to a patient that you don't belong or shouldn't be here. You know, I think our patient story really showed how we try and give everyone privacy and dignity. It is absolutely no fault of the person. They find themselves stuck in any service. What we do try to do is do the reablement. So I think Wilvor was the best example of that we changed one of our units into a reablement unit that was therapy-led, and the multidisciplinary team around that was a GP, AHPs, nursing, and using our other community services, such as our care home, our Louisa, who is the consultant nurse in the care homes, working with the GPs to try and find how we could get the patient to their destination of choice. It is not easy, but we continue to work with all partners in a reablement fashion to make sure that the patient continues to get the care they require whilst we find the next suitable discharge option for them.
Thank you, Chair. I'm going to ask questions 7 and 8 together because they came in on the same theme, both to Robin as the Acting Chief Operating Officer. The first is from Peter Levin and the second is a response from Anonymous. Peter asks, would it not help in avoiding having to function as a proxy aged care facility if former community hospitals like Edward Hayne and St Ives were reopened as convalescent homes, able to take precisely these people? They should be led by therapists who are accustomed to processes rather than clinicians who are conditioned to think in terms of treatment episodes, and their patients would know that their reablement is the prime concern of the establishment. Anonymous then states that Mr Levin makes an interesting point and asks about making use of the 3 care homes with over 100 beds mothballed by Cornwall Care. Thank you, Robin.
Thank you, Peter and Anonymous. Both those sets of facilities don't belong to RCHT. I will pick up with colleagues in CFT and system partners your suggestions there. It is worth noting that, as Kim's already mentioned, the Wilvor model, that model of practice where therapy-led actually moved from this site to one of the wards in CFT. So we're still providing that therapy-led and reablement service as you describe in at least one of those areas. Thank you.
Thank you very much, Robin. Okay, thank you. So there are no further questions from members of the public. I do thank you for those questions. We highly value them, and I hope that we've been able to give you adequate replies. Then we have item 17, which is our items for information, and these are starred items. And I have not had any questions raised with me in advance. So I am going to therefore ask that the board note the Board Assurance Framework and Corporate Risk Register were approved by the board on the 4th of August and have been included in the current pack for transparency. And also to note the decision taken via e-governance in July 2020. 1 or 2? start again. Note the decision taken via e-governance in July 2022 to delegate authority to Quality Assurance Committee to approve the neonatal element of the CNST maternity submission. So if we could note that, please. And then come to item 18, where we reflect on the meeting and ask ourselves what went well, what could have been better, how would have been more effective, have we been consistent with our board etiquette, and have our discussions today contributed to patient safety? And there's always a slight delay until anybody answers this, because we're not used to being in reflective mode because we've been in board mode. But if colleagues have comments that you'd like to offer just now, Robin.
Thank you. I think we have contributed to patient safety. I believe that we've been very open in this board. We've explained on our integrated performance report where we've got challenges, and we've identified where there's areas that we would like to have seen more improvement but haven't yet. And I think we've described, and the committees pre this board have challenged us on how we take those actions to drive that forward. So I think we've had a really transparent conversation today on some of the challenges that we face.
Thank you, Robin. Ruth.
Thanks, Mary. I think we've had some very good discussions today, and I think the timing felt a better pace today as well, even though we had a half an hour break. And I think I particularly want to reflect on the questions that we had from the public. To have 8 questions and such thoughtful questions is a real bonus to us in the work that we do.
Thank you, Ruth. I couldn't agree more. It really does help us, and one of the things we want to go on getting better at is more and more communication with members of our public for whom we work. So that's a really helpful question. Nina, I think you were next. Oh, sorry, Kim, you were next. I beg your pardon.
I know I'm chief nurse, and I know I'm going to say this, but I think the patient's story really grounds the meeting. We share the good and the bad, and we're prepared to. So it doesn't matter. We are talking about patient safety, but I think that Tom today put a face on what our patient experience is and what we all need to do better to make sure that our patients, clients, our families get the right care in the right place at the right time.
Thank you, Kim. And I do think for those of us who are board members and not clinically facing very much of the time, it does make so much difference to have those real stories. And I think as we get on with our walkabouts now, that'll be better for us. But I think that was a brilliant story, Tom, if you're still with us. I also can't help but comment on the cartoon presentation. A number of people on the board have said how lovely it was. So for whomever actually did that, thank you. Now, Nina, your turn.
Thanks, Mary. Thanks, Steve. I thought it was an incredibly effective meeting, and as you've said, discussing challenging items and respectfully asking questions of one another is what we're here to do. What I also felt is really important is that we are not only the board, but we are actually service users ourselves. We live in Cornwall, we have families, and we will be hopefully not using the service, but it's there to serve us as well. So I think that's a really important point for us to realise that we are all on the same side, and so we're all improving quality and patient safety should ever any one of us or our family members be on the receipt of medical care. Thank you.
Thank you, Nina. I think from my perspective, I think it has been a well-paced meeting, so my thanks to Sian and colleagues who helped with the agenda setting here. I think it was great to have Kate and John join us, and I hope we see more of that. We are feeling our way into how to work well as a whole Cornwall and the Isles of Scilly system, and I liked the points that were made about the inclusion of all sectors sectors. It's not just us as NHS, it's other public sectors, but it's very importantly members of the public and people who are volunteers. And I think that's really worth remembering. I also particularly like the bits about the warm public spaces. I thought that was very important, and others will have heard the same as I have recently. I think it was in Newcastle, they're talking about, I can't remember what they call it now, warmth banks, where public spaces such as our own, but also private citizens, are being asked to open their homes for a couple of hours. Warmth. I just think that's such a brilliant concept, and I'd really like to see us do it more. So it's lovely to hear that in our agenda. So I think the other thing is to say that I think our papers are getting better, which is great, and I think that the continued brevity of presentation, so we get more time to actually talk and comment. I know some colleagues worry about keeping everything succinct because they want to give people the credit of all the work that's been done, and I understand that, and we want to do it, but actually I think the best way we can thank people for what we do is to really listen and then challenge and make comment on, so having that space to have a good board strategic discussion is really important. Are there other comments? I don't think so. So can I thank everybody very much for attending this meeting, and let folks know that our next board meeting in public will be on the 3rd of November. The board is now going to take a short break, and then we will move to our private session to consider matters deemed confidential as per the notice on the end of the agenda. So thank everybody very much indeed for your time this morning. Thank you.